posterior fossa tumor, and it is a rhabdoid tumor of the kidney and ATRT of the in the posterior fossa. So we have to deal with them simultaneously. If we don't remember this entity, perhaps we will go ahead with the abdominal surgery, which can be catastrophic with the posterior fossa tumor in place. And these are generally very difficult tumor to treat with whatever you do. They are generally resistant to therapy, and most of them, they have a mortality very soon. The other common tumor is a clear cell sarcoma. Means next to Wilms tumor is a clear cell sarcoma, and mean age is 39 months. It's the second most common type of renal tumor with a metastatic potential to bone, very commonly associated with bone metastasis, and can also have a soft tissue, lung or brain as a metastatic sites. The late relapses are known, and generally they present with, many of them present with bone metastasis, and incidentally you also have the renal tumor and you can correlate. It has a higher mortality too, but with the current management, at least it is better than the rhabdoid tumor. The other tumors which we can come across in this age group is congenital mesoplastic nephroma, which is also very young, and median age at presentation is 2 months. And the cellular variant resembles many other entities like infantile fibrosarcoma, and generally they are small and restricted. So we always say that in a child who is very young, if you have a renal tumor and it is operable, generally you must undertake surgery first, because you can have this entity called congenital mesoplastic nephroma. And if it is not very highly cellular and overlapping with the features of Wilms tumor, surgery alone is the treatment. So we must do the surgery upfront if there is a it is an operable tumor. What is all this? The other one is a cystic partially differentiated nephroma. Cystic nephroma, and this is a variant of Wilms tumor, but they are very largely cystic with only small tumor at the periphery, and generally they have an extremely good prognosis, and even if you give chemotherapy, they generally don't shrink, and surgery is very, very important. So not looking at the size, you must undertake surgery in such tumors. I just just this is a
लोगों ने मेडिकल कॉलेज से लेट ज्वाइन करे, कोई नहीं था वैसे एलिजिबल, कोई भी नहीं. मधुबाला मैम अभी बनी है प्रोफेसर यहाँ आके.
Can we request everybody to mute themselves, please? So we have certain congenital anomalies. 12 to 15% of Wilms tumor come with congenital dysmorphic features which are very visible, and you can see this congenital anomalies in the form of genitourinary, which is the most common, 4.4%, hypospadia, cryptorchidism, pseudohermaphroditism, horseshoe kidney, double collecting system, or ambiguous genitalia. So these are the phenotypic features which as a pediatrician or a pediatric surgeon, you may come across, and you must make a note of it and try to go more in depth whether you are not dealing with a Wilms tumor. The other congenital condition which is very commonly seen is sporadic aniridia, and generally many of the growth axis syndromes, they are more prone to get Wilms tumor. Particularly, you will come to know that why it is so. It is a Beckwith-Wiedemann hemihypertrophy and These are the two very common hemihypertrophy and Beckwith Wiedemann of a growth axis syndrome, which can be associated with Wilms tumor. And there are intrinsic renal abnormalities which you can get in Wilms tumor. And this is nephroblastomatosis. When nephrogenic rest, they collate and form this island called nephroblastomatosis, multicystic kidney, and a Danish Drash syndrome. So these are the congenital anomalies which are commonly or which are associated with Wilms tumor. And if you get a child with this kind of a presentation, one should keep in mind the possibilities of Wilms tumor. This is just Beckwith-Wiedemann syndrome with a growth axis and aniridia. Now, as we know, just not going into the absolute details, but what I'm trying to say is that Wilms tumor are basically a developmental anomaly. We have to look at it as a renal development anomaly. Like when you have a embryogenesis of the whole kidney and the urogenital system, you have a normal development where this nephrogenic rest disappear and form a normal kidney, or you have a nephrogenic rest and their gene, that is WT1, gets inactivated. WT2 means these are the either gain or losses which can lead to embryonal type of a persistent embryonal kidneys, and then further inactivation of LOH like P53 inactivation, LOH16Q1P. So there are basically, what I'm trying to say is that it is not a very complex, it is a complex and multigenic event where there is a primary events which is involved in genesis. That is the embryologically, the nephrogenic rest have not disappeared to form a normal kidney. And then you have a another cause to promote this into the Wilms tumor, that is WT1 gene, which is associated with WAGR syndrome, Danish Dress syndrome, and WT2 gene, which is associated with the Beckwith-Wiedemann. So that is how this growth axis syndromes, they have this because they are associated with these genes. And this is where we remember this gentleman called Knudsen, who postulated this two-hit hypothesis, that you have one hit inside the utero and the second hit is outside when the tumorigenesis can happen. And these are just the implicated genes with all the syndromes, which are also part of the development of the Wilms tumor. So this is just a basic understanding as to why it is a developmental defect. Like in embryogenesis, when the kidney is formed, the first hit has occurred, and some of these hits may go unnoticed and may not turn into Wilms tumor, while the others may have the second hit and turn into Wilms tumor. The nephrogenic rest which persist, the small patches which I showed you in my first tumorigenesis slide, this is an abnormally persistent embryonal nephroblastic tissue with clusters of blastemal tubules or stroma cells. They are intra or perilobar, and nephroblastomatosis is a multiple nephrogenic rest which come together, and few develop this clonal transformation to Wilms tumor. And therefore, there is a need for, if you have a nephrogenic rest in a Wilms tumor child, then you need to monitor the other kidney also for tumor development, mainly in young infants, because you can have a bilateral Wilms tumor which may happen synchronously, that is together, or at a different point in time, that is metachronous. And that is how the if you have a Wilms tumor child who has to undergo nephrectomy, and you have a situation of nephrogenic rest, the opposite kidney also needs to be monitored, and it has to be saved. That is why it has to be monitored very carefully. And the multimodal treatment of Wilms tumor revolves around surgery, radiotherapy, and chemotherapy. And each one is a topic by itself and will be dealt by my colleagues. And policy of management mainly depends on the stage of the disease and the histological feature. We decide the risk of the tumor. Risk for relapse and possibility of survival. National Wilms Tumor Study Group of United States very systematically shown that how addition of other modalities beyond after nephrectomy has improved the survival rates over a period of time. And addition of radiotherapy, addition of vincristine actinomycin D, and then further understanding the biology of the disease to risk stratify and treat each tumor properly as per the risk has led to this success story. So what have we learned from this past? That early results with adjoint therapy in form of radiotherapy and actinomycin D alone, they led to around 58% with meds and 89% without meds. Thus, Sidney Farber reported long back that it was based upon the supposition that in the children with Wilms tumor who died, the tumor must have metastasized already at the time of discovery of the primary tumor, although no evidence of spread was available. And this was in 1966 it described, and now we all understand this concept of micrometastasis, which we always talk about in pediatric solid tumors, and we consider all pediatric solid tumors as having a potential of micrometastasis, and that is why chemotherapy forms a very important part, sometimes even before surgery and definitely after surgery as adjuvant therapy. So that only has resulted into very good results. So this Wilms tumor was the first prototype which demonstrated this concept, and this is how it has progressed over a period of time from 1969 till recent. I'm not going to go into the details because each topic will be dealt with by my colleagues in details. And International Society of Pediatric Oncology also started this new adjuvant chemotherapy concept as to how giving some form of therapy before surgery makes the surgery better, and how it can be done first starting with radiation prior to surgery, and then now only giving chemotherapy prior to surgery. And these are the algorithms which National Wilms tumor, this is transatlantic, basically in USA, they believe in first surgery and proper staging, followed by stage and risk stratification, and then deciding the further line of management. While in PSYOP, it is mainly the neoadjuvant therapy followed by surgery, and then giving a stratification or a staging and a risk stratification pathologically to decide the further line of treatment. And these two approaches are totally independent, and one definitely has to remember as to how they are complementary to each other, but they are not overriding each other. So the approach, one has to follow one algorithm, and that if you follow PSYOP algorithm, surgical staging plus histological findings, they are all belonging to that group. If you follow the NWTS, then you follow that because they are not interchangeable. And these are the NWTS 5 mature results which have come out. And as you can see, for stage 1, it is in excess of 90%, and down the line, even in stage 4, 3/4 of the 75% of the patients can be cured. And even in anaplastic histology, the results are quite good as far as this lower stage is concerned, but it drops down to less than 50% for stage 4. And in PSYOP also, you have a similar survival in excess of 90% in many. So now there is a renal tumor study group, which combines the whole, and it has an ambitious plan of collating all the WIMS and non-WIMS tumor under one roof. And that is why it is called as the umbrella protocol. And that is the current uh, attempts is to defining all the WIMS tumor properly into stages plus non-WIMS tumor also into the same group. And there is a guideline for treatment, uniform treatment for each one of them. So where do we stand today? Most children with WIMS tumor survive long term, regardless of the sequence of therapeutic interventions. Like I showed, NWTS and PSYOP are complementary to each other as far as the survival is concerned. There is a problematic group, however, which still needs further attention, which is anaplastic histology, bilateral disease, favorable histology with high risk features, which comes out particularly in PSYOP after chemotherapy. If you have a persistent blastema, indicator of a resistant disease, then this all put together, they form 25% of the all WIMS tumor, and they need to be further optimized for their treatment. Otherwise, WIMS tumor is a real success story, and that is a prototype of solid tumor, how it should be treated. And this has been even taken as an example by the adult medical oncologist. And when we have such a high cure rate, we give a prize for this cure. And the various late effects which you can get are significant, particularly with cardiac, 25% of the cases because of the use of anthracycline, and musculoskeletal, because you are not careful with the radiation, then you can have a, when you give truncal radiotherapy, it can give rise to problems of the growth. And in a even nephrectomy child, there is a 1% chance of renal failure, and there is a bilateral, mainly in the bilateral cases. So one has to be very careful, but particularly if you have a syndromic child who can develop the bilateral WIMS tumor, even if you have not seen it now, there is a possibility, and one has to be very conservative and try to spare as many nephrons as possible to preserve the renal functions. And thus, I would end by saying that cure is an intermediate outcome in childhood cancers, because this is very highly curable. So goal is to cure these children with good quality of life. And that is why all this developments and further risk stratification and optimization is happening, and you are going more and more into the depth of the whole thing, because the goal is not only the cure, but goal is cure with good quality of life. Thank you. And now I hand over this platform to my colleagues to take care of each aspect in further details. Thank you.
Thank you, ma'am, for the detailed overview of renal tumors. We now go on to our next speaker, which is Dr. Kirti Hegde. She will be talking about clinical presentation of WIMS tumor. Dr. Kirti Hegde has completed her MD Pediatrics from D.Y. Patil Medical College, Hospital and Research Center at Navi Mumbai, and later pursued Fellowship of Indian Academy of Pediatrics in Pediatric Hemat-Oncology from Lokmanya Tilak Municipal General Hospital, Sion. She's also been a clinical fellow Pediatric Hematology Oncology in Great Ormond Street Hospital, London, working at prestigious and high-volume centers like LTMGH and TMH in Mumbai. She has honed her clinical and procedural skills pertaining to pediatric hemat-onco. She has a keen interest in late effects and has an experience in conducting late effects clinic at TMH Mumbai. In the last 2 years of training in the United Kingdom, Dr. Kriti has taken part in presenting complicated cases in interdepartmental as well as national MDT. Her time at Great Ormond Street Hospital has trained her in delivering treatment to children previously deemed to have poor outcome and go above and beyond in trying to find available options, especially in the day and age of targeted therapy including immunotherapy. Her outlook towards treating cancer has broadened and taught her her role as clinician is to be compassionate and provide holistic care. Dr. Kirti also has a keen interest in clinical governance and strives to maintain high standards. She has taken part in many audits and organized various MDTs between allied teams to optimize care for children with complex needs. Over to you, Dr. Kirti.
Thank you for that kind introduction. So I'll be dealing with the clinical presentation of Wilms tumor. So we've already heard that Wilms tumor is one of the most commonest renal tumor in children between 1 to 5 years of age. It nearly encompasses 87% of the cases, followed by clear cell sarcoma, which constitutes about 6% of the cases, followed by rhabdoid and mesoplastic nephroma, which constitutes 2%, and then other tumors constitute the remaining 3% of renal tumors of childhood. Now, any tumor, any abdominal mass can give rise to symptoms either because of the mass itself, or it could be because of the disruption of the organ functions that is caused by compression, or these symptoms can arise because of the metastatic disease. Now, the commonest presentation of a Wilms tumor is that it's mostly asymptomatic. The history you always tend to get is this mother was bathing the child, finds an incidental knot in the abdomen, and that's how they generally present. Sometimes, very rarely, can this mass cause urinary obstruction, or it might cause compression and thus causing constipation. 40% of these cases present with pain, and pain does not always mean that this tumor has ruptured. Children with Wilms tumor can also present with gross hematuria, but again, most common presentation would be microscopic hematuria. Even more rare presentation would be when a child comes with signs of metastatic disease with dyspnea, as Wilms tumor generally metastasizes to the lung, or pain. As we've already heard in the previous talk, that Wilms tumor children with Wilms tumor can have a syndromic association, and they generally 10% of these children have an underlying syndrome. 2% of them can have underlying heart defects, and a very small percent of these children might come with systemic signs like fever. Now, the syndromes that are associated with Wilms tumor, we have the WT1 syndromes, such as the Vagger, Denny-Strash, or Fraser syndrome. Now, Vagger, it stands for Wilms tumor. Can everybody please mute themselves? Thank you. Right. So we were on Vagger syndrome, and Vagger stands for Wilms tumor, aniridia, genitourinary abnormalities, along with mental retardation. Vagger, generally, these children have a predisposition of developing Wilms tumor, and it accounts for about 30%, and it arises due to deletion of the WT1. The other WT1 syndrome is the Denny-Strash. These children have ambiguous genitalia. They undergo early renal failure because of diffuse mesangial sclerosis. Children with Denny-Strash, nearly 90% of them will develop Wilms tumor at some point in their life. The other syndromes that are associated with Wilms are syndromes of overgrowth. So you have the Beckwith-Wiedemann. Beckwith-Wiedemann presents with omphalocele, macroglossia, and gigantism. 5% of children with Beckwith-Wiedemann can develop Wilms tumor. More common tumor with Beckwith-Wiedemann is actually hepatoblastoma. The other overgrowth syndrome is Simpson-Gulabi. These children, other than overgrowth, have craniosynostosis. And children with this syndrome, 10% of these children can develop Wilms tumor. What you see in the bottom half of the slide are all syndromes that have a hereditary predisposition to cancer, such as Lee-Fromeny, Fanconi, Bloom, and trisomy 13 and 18. What you see here is children with Fanconi D1 have a higher predisposition to developing Wilms tumor. Almost 20% of them can develop Wilms tumor. Now, this was a paper published by the Dana-Farber group, and it goes on to study 200 children with Wilms tumor. Of these 201 children, 8 of them had some sort of genitourinary abnormalities. And out of these 8, 6 of them had constitutional WT1 syndromes. So it goes on to show that if you have a child with the underlying genitourinary abnormality, of which cryptorchidism is the commonest, always think of doing germline mutations, as if you do pick up a constitutional WT1, it would be imperative because it will help us with follow-up, as they can develop Wilms tumor at later on at some point in their life. And it also sort of helps with planning surgery, as we've already heard that these children would need nephron sparing surgeries as opposed to nephrectomy upfront. Now, evaluating a child with an abdominal mass. What we need to look at would be history is the most important. And always asking for history of prematurity, as premature children are more predisposed to developing hepatoblastomas. So it helps in narrowing down your diagnosis. Always going in depth to find any family history of cancers, looking for genetic predispositions also helps in narrowing your diagnosis. On examination, where is this mass? Can you localize it? How does it feel? Because Wilms tumor generally are firm, rounded mass, and always have a light touch when you're examining this mass, because there's always a theoretical risk of rupture. Now, if your child on examination has hypertension and an abdominal mass, the 2 tumors you think of would be neuroblastoma and Wilms tumor. About 1/3 to about half the cases of children with Wilms tumor end up having hypertension. The cause of this hypertension has been linked to excess renin. There have been multiple literatures that have been published where children with Wilms tumor have had an excess of renin. And this could be because of the tumor itself producing renin or the compression that is caused by the tumor. And by this logic, what they have also claimed is that generally ACE inhibitors and angiotensin receptor blockers work better than our standard calcium channel blockers. So if you have a child with Wilms tumor where you have refractory hypertension, then always try to add in an ACE inhibitor or an ARB, provided there is no renal stenosis. Your examination will be incomplete if you've not looked for any syndromic associations that we've already discussed in the previous slide, such as aniridia, any absence of iris, genitourinary abnormalities, and hemihypertrophy. Now, how do we approach? We have an abdominal mass. Now, going by age and location of the mass, so we've classified this into 3 groups. We have neonate, less than 1, then children between 1 to 10, and your adolescent age group. Now, in the neonatal age group, if you have a neonate who's presenting within 1 year of life with an abdominal mass, always think common things first. So generally, 50% of these masses turn out to be of the urinary tract, and the most common cause would be hydronephrosis. If it's a male child, the other common diagnosis to think about would be a posterior urethral valve, or a multicystic or a polycystic kidney disease. Tumors in this age group is rare, but if it does happen, then think about mesoplastic nephroma, a rhabdoid tumor. Wilms tumor would be very, very rare. In the genital tract, you might see ovarian cysts or sacrococcygeal teratomas. If this is a suprarenal mass that you're picking up on the ultrasound, then the likely etiology could be a hemorrhage or a neuroblastoma. In the GI tract, think about pyloric stenosis, hernia, intussusception, malrotation, or a mesenteric cyst. Between 1 to 10 years of age, in the genitourinary masses that presents as abdominal mass, again, hydronephrosis, bladder distension are the more common differential diagnosis. If you're thinking about tumors, Wilms tumor comes higher on the list, followed by rhabdoid tumor and other sarcomas of the kidneys. Adrenal masses in this age group generally tend to be neuroblastomas. And if this is a liver enlargement, it could be secondary to CCF or any metabolic diseases, infections. Hepatic tumors that present in this age group are generally hemangioendothelioma, hematomas, or hepatoblastomas. In the adolescent and young adults, the genitourinary abnormalities, again, hydronephrosis goes across all the age groups. It could be a bladder distension, or it could be, if lower down, think about pelvic masses, then you think about some sarcomas like Ewing's or DSR-CTs. In the genital tract, we think about GCTs and dysgerminomas. Differentials for a liver mass, again, could be secondary to CCF, metabolic, or infections. If it's a hepatic mass, thinking about malignancy, then more common than hepatoblastoma in this age group is hepatocellular carcinoma, or it could be a secondary met arising from somewhere else. Leukemias are also one of the differentials in this age group. In the GI tract, your differentials would include hernia, intussusception, or carcinoma, which is extremely rare. How do we evaluate these children? So we are done with history, we're done with examination. Now CBC, renal function, liver function, generally we ask for. Uric acid and LDH is not of second nature to us, but abdominal masses in this age group, your closest differential, it's always a confusion. Is it renal? Is it suprarenal or anything else? So it is good practice to do uric acid and LDH, as uric acid and LDH would generally be elevated in your closest differentials like neuroblastomas or leukemias. Now, the other thing that is of interest in Wilms tumor is that 1 to 2% of children with Wilms tumor might have an underlying acquired von Willebrand disease. Generally, their APTT may be prolonged, but like other von Willebrand diseases where you might have a normal coagulation profile, but if your suspicion is high, if they're bleeders, then think about acquired von Willebrand disease and evaluate them accordingly with von Willebrand factor antigen, factor VIII, and risotectin cofactors. And what you generally tend to see is that if you do see acquired von Willebrand disease, it generally resolves with preoperative chemotherapy. Now, coming to this question, do we biopsy this tumor? Do we not biopsy this tumor? Now, Wilms tumor is generally a radiological diagnosis. Now, different parts of the world treat it differently. So as we've already heard, there is an American approach and there is a European approach. Americans tend to operate first and then give adjuvant chemotherapy. However, the Europeans tend to reduce the size of the tumor, shrink it, make surgery slightly easier, and then do neoadjuvant. Both have their merits and disadvantages, but the conclusion is that there is no survival advantage of one over the other. So NWT, as it operates first, you've proven it's Wilms and then treat it. However, PSYOP, there's always this question, are you treating Wilms or not? So PSYOP has some indications where they do biopsy. In a child who does not fit the age criteria, so age less than 6 months, or if the presentation age is more than 7 years, previously it used to be 10, then it's a definite indication to do a biopsy. If a child has presented with signs of TLS, systemic signs, hypercalcemia, LDH more than 4 times of the upper limit, then they would consider to do this biopsy. Generally, these tumors are treated in an MDT approach. So if your radiologist says that they're not comfortable calling it Wilms, there is some asynchrony, or there are unusual METs, or METs in less than 2 years of age, then it's a definite indication to biopsy this tumor. What do we do? So ICMR had published this consensus statement in 2016. And over here, it's sort of a hybrid approach. If the tumor is small, surgeon is comfortable, sometimes you go the American route. But if it's an inoperable renal mass, and you do give chemotherapy, there's always this question, what are you treating? As 10% of these tumors can be non-Wilms. And if it's a non-Wilms, it is not going to respond to your box standard chemotherapy, which is vincristine and actinomycin. Now, generally the ICMR, the consensus statement says that if the age again, like PSYOP, is not fitting, you would think about biopsy. If there's an unusual presentation with infection, septicemia, you again think of biopsy. And the third indication would be on imaging, you're seeing calcification, huge nodes that do not fit with Wilms tumor, or the entire renal parenchyma is involved, you're not able to see anything, then we would definitely think about biopsy. Now, when you do a biopsy, what is expected is that what is preferred is a retroperitoneal approach and an image-guided needle biopsy. Again, if it's a bilateral tumor, there is really no differential. You may actually skip and you may not need a biopsy at all. Wedge biopsies and open biopsies are an absolute contraindication. Now, 12% of these tumors could be metastatic at presentation. Locally, they can spread through the renal capsule into the perirenal fat. They can traverse through your blood vessels and form a tumor thrombi. They can go to the regional nodes and involve them. Distant, they go through the hematogenous route, and they can go into your lung, which is the most common site for metastasis, followed by liver. If you're seeing a met in the brain or a bone, then always question the diagnosis, because WILMS does not do that, and think about rhabdoid or clear cell sarcoma. Imaging and staging will actually be dealt in great detail by my colleagues, but I think a picture speaks 1,000 words. And just to make it really simple, because the staging can be quite complicated in WILMS. Stage 1, when you have a tumor this is a post-op staging. So this is only after the surgery. If you have a tumor that is sticking within its spaces, within the capsule, it's stage 1. It has encroached the capsule, but you're able to completely remove it. It is stage 2. If your nodes are involved, or you've left behind the tumor, or there has been a spill or a rupture, then it is stage 3. Stage 4 is when you have a distant met, either to your lung or a liver. And stage 5, which is again quite unique to WILMS, is when you have both the kidneys involved. Now, like evolution of any treatment, WILMS tumor with such good outcome has also evolved quite a bit, and molecular has come into play even in WILMS. These tumors, about 17% of them may have loss of heterozygosity on chromosome 16 or chromosome 1. And generally, these are the poor players. And NWTS has demonstrated a 2 to 3-fold increase risk of relapse in such situations where you had a loss of heterozygosity of 1 or 16. However, 16 has not been replicated continuously. And now in the umbrella protocol, they're actually stratified as per these molecular aberrations as well. That brings me to the end of my topic, and Hirin will be taking over to speak about radiology.
Thank you, Dr. Kriti, for that wonderful talk. We now introduce our next speaker, Dr. Hirin Panwala. Dr. Hirin is a young and passionate, enthusiastic pediatric radiologist who always thinks first for the child who needs treatment than anything else. He has done his DNB radiology at Sir Gangaram Hospital, New Delhi, and was awarded the fellowship in pediatric radiology at CMC Hospital, Vellore. He has done refined and intensive core pediatric radiology training at CMC Vellore during his senior residency and assistant professor tenure. He's a core member of the Radiologist.com, whose intention is to spread knowledge globally. He has core academic passion and has been a faculty speaker in various national and state level radiology conferences. He believes in philosophy of not letting the passion or skill to get wasted as the world needs it. Over to you, Dr. Hirin.
Thank you, Dr. Rujul. Am I audible?
Yes, sir.
Yeah. So I'll be talking briefly about the imaging in immune tumor, and I'll be showing the maximum images so that you can understand. So these are the different imaging modalities that we can use for the assessment of any renal tumor, including the WILMS tumor. So the X-ray chest is required for the follow-up for the chest metastasis at surveillance, and it is also useful for the initial evaluation. USG, as we all know that in pediatric population, that is the initial modality for any abdominal or renal mass. It is especially useful for the biopsy because by USG guided, you can take the solid portion of the tumor and you can actually see from which portion to biopsy it. And it will be real-time modality and it is reagent-free. So that makes it more plus point for the pediatric population. CT and MRI, they are the investigator of choice in terms of renal tumors. And they will be useful for the loco-regional as well as distant spread. And CT or MR both are having equal sensitivity, specificity in picking up the WILMS tumor. However, for lung metastasis, it is advisable that we should do CT thorax with contrast at the initial pre-operative or first-time imaging. DMSS scan is sometimes required before surgery to assess the functioning of the tumor if we are planning for partial nephrectomy. or certain specific scenarios. And sometimes we need to do bone scan if we are suspecting any malignant renal tumor like clear cell sarcoma who has propensity to have bony metastasis. In those kind of situations, we can do bone scan. So our main objectives of the imaging in Wilms tumor is, first of all, we have to identify the origin of the tumor, whether it's arising from kidney or somewhere else. We need to see the size as well as extent of the tumor. We need to see the involvement of the renal vascular pedicle. Of course, we need to mention about the lymph nodal metastasis and whether the tumors are only in one kidney or it is bilateral, and also to detect the distant metastasis. So there is a nice article which has shown imaging approach to pediatric renal tumors. So they have tried to simplify how we can go ahead based on the solid or cystic nature of the lesion. And based on the age of the patient also, we can somehow narrow down, or we can diversify the differentials, and we can think about those possibilities. For example, if it is a solid tumor and less than 1 year, then we should think of these differences like mesoplastic nephroma or abdo tumor that my previous colleagues already mentioned about these facts. And if it is more than 1 year, then the most common is Wilms tumor, that 85 to 90% of the renal tumor at this age group will turn out to be Wilms tumor. But these are some other DD. And this is the flowchart for the cystic lesion, which I am not going to detail. There are some secondary tumors which can occur in pediatric population, lymphoma, leukemia. We might see 1 or 2 examples of this also in today's talk. So this is the classical ultrasound appearance of the Wilms tumor and you can see that this is the native kidney. And from the lower pole of the native kidney, we can see this is a well-defined round shape lesion which is arising and growing exophytically from the kidney. And the lesion shows this kind of anechoic, tiny cystic areas, and this hyperechoic material, which could be hemorrhage also. And that's how, like, the role of ultrasound is identifying that is there any solid or cystic lesion within the kidney, and then look at the size of the lesion, and of course to assess the vascularity, whether it is extending into the renal vein. Those kind of information can be, or IVC can be given by the ultrasound. This is the CT appearance of the Wilms tumor, in which we can see that on CT, there are certain signs which helps us to identify that whether the tumor is arising from the kidney or it's arising from somewhere else. So one of the sign is this claw sign. So you can see here that whenever there is the tumor is arising from the kidney, it will cause this kind of bulge towards outside or exophytic growth, and it will have this kind of obtuse margin. Instead, when the mass is not arising from the kidney, it will cause infolding of the renal tissue. It will cause compression of the renal tissue, and it will have an acute angle with the renal margin. So this is the difference between the claw sign versus any mass like neuroblastoma, which is pushing the kidney and displacing the kidney. So here we can see that this is the normal renal tissue, and that is the claw sign, which is causing splaying of the kidney parenchyma and this mass formation, and that is having this kind of obtuse angle with the normal tissue. So that is confirmatory that the lesion is arising from the kidney itself. Then you can assess the vascularity and local adenopathy and etc. So here is the CT has this kind of multi-planar reconstructive imaging availability, so that we can actually say that whether the renal artery is encased or in this case we can see that it is significantly splayed and compressed by the mass lesion. And sometimes this renal artery compression itself can cause hypertension in a patient. So in that way, CT really helpful in deciding what to do for the child. There are some other features that CT or MRI can detect. That is the invasion into surrounding structures. Like you can see that there is a blood merging with the ipsilateral psoas muscle. This is the psoas muscle. So that kind of information, as well as is there any perinephric neovascularity or perinephric spread of the disease that can be seen by this kind of heterogeneous soft tissue density areas within the perinephric space, which indicates that there is perinephric spread of the disease. There are certain key imaging findings when we are assessing on CT or MRI. For example, if you see any pulmonary nodules, then that could be metastasis, and that makes the stage as stage 4 disease, which is very important to pick up. And if you are seeing tumor thrombus or embolism, that also keeps the staging higher, and it will be considered as stage 3. If the tumor thrombus goes into the heart, then primary nephrectomy may not be possible, and that is not advisable. We should be able to see that is there any ureteral extension and is there any retrobasal hemorrhage. So this retroperitoneal hemorrhage also, if it is preoperatively ruptured, that also makes the staging into stage 3. And if you are seeing lesions on both sides, that is the bilateral renal lesions, that will make it as a stage 5. And whenever we see stage 5, we should always look for underlying tumor predisposition syndrome conditions that Dr. Kirti and Poona madam already described before. We should also look carefully for the liver for metastasis and peritoneal cavity for the drop metastasis and adjacent organs for infiltration. So this is the staging that I'm not going to detail because as Dr. Kirti has already conveyed this. I'll be straight away showing you the example of different stages. So this is the example of Wilms tumor, which has gone into adjacent organs. In this example, we can see that the tumor has gone superiorly and it has infiltrated the right lobe of liver. You can see that the margin with the liver and the tumor is not well defined. It is blurred margin that indicates that there is contiguous extension to the liver parenchyma. Here is one of the example of retroperitoneal hemorrhage. So when you only just a mild ascites will not indicate tumor rupture. So when you are saying tumor rupture in the report, that you should be able to see this kind of high density fluid, which is tracking in the perinephric space, as well as sometimes it can track into the peritoneal space. So when you see this kind of heterogeneously high density within the retroperitoneum and peritoneum, that indicates that a tumor is rupture and that makes it more higher stage. Here is the example of tumor thrombus, which is going into the right atrium. This is the right atrium, and that is the IVC. Now, you should be able to identify tumor thrombus. One thing is that it will have density similar to the primary lesion. If you see that the enhancement characteristic is similar to the original tumor, and it will distend the vessel or the chamber where it has gone. So these are the markers that we can identify that tumor thrombus is there in the right atrium or IVC or renal vein. Sometimes you may see liver metastasis also. So this was a case of Wilms tumor, which was having this kind of multiple peripheral hypodense lesion, which were indicative of liver metastasis. The same, this one other example in which there was right renal vein thrombosis, that we can see that the renal vein itself is expanded. It shows the similar density area of the tumor tissue extending into the renal vein. And the same patients also had this kind of pulmonary thromboembolism. You can see that these are the right and left pulmonary branch arteries, which are showing this kind of luminal filling defect, which is also having similar density to the primary original March tumor, and which is expanding it. So it is really important to look at carefully the pulmonary arteries also, because sometimes the pulmonary thromboembolism can occur through this tumor thrombus. This was a very unusual case that we recently saw in our multimodality meeting, in which the child had earlier nephrectomy on the left side. And after a few years, the child presented with this kind of multifocal peritoneal and retroperitoneal metastasis. So that also very important, that can be detected by the CT and MRI, and which is important for stating any treatment. We should be able to identify the local as well as distant adenopathy. So the loco-regional adenopathy is quite common in, it's not uncommon in the Wilms tumor. For the size criteria, usually we take in the retroperitoneal space as a 1 centimeter. And not only size, we should see the morphology also. If the tumor shows necrosis and it has lost its oval shape, then or it has become round shape, that is suspicious for the lymph nodal metastasis. And here is the example in which the tumor has gone inside the pelvis. You can see that this is the pelvis of the native kidney, and that is the ureter, which is showing excision of the contrast. So we can see that extension of the tumor itself in the PCI system. A few words regarding the tumor thrombus. So the tumor thrombus, it can be detected on CT or MRI, and in doubtful scenario, sometimes ultrasound also can be useful. And how to detect tumor thrombus, that we have already mentioned, that it should distend the lumen and it should have similar enhancing component as the primary tumor. Now we'll be seeing some other differentials of the Wilms tumor as a renal mass, solid renal mass, which can mimic like a Wilms tumor, and what we should be looking for, or when we should say that this could be something else rather than Wilms tumor. So there are certain imaging as well as clinical features that helps us. First of all is that age of the patient. If the age of the patient is between 1 to 11 years, then we can expect Wilms tumor. However, if the age of the patient is less than 1 year, then that's one of the signs that the patient might be having some other tumors like nephroblastomatosis or mesoplastic nephroma or rhabdoid tumor. And generally, the rhabdoid tumor may have associated brain neoplasm that we'll be seeing in one of the case subsequently. So here is one example, 1 year, 4-month-old child who came with painless gross hematuria for 10 days. The patient had no history of fever and dysuria. What we saw that there was some expansile mass lesion, which was heterogeneously enhancing and showing areas of necrosis as hypoattenuating areas. And the patient also had this kind of subcapsular hypodensity, which indicates subcapsular rupture of the tumor. And the lesion was displacing the IVC, but there was no tumor thrombus. But in this patient, we could see that there were multiple this kind of peripheral based solid nodules were there in bilateral lungs. Now, how to say whether the lesion is lung metastasis or infection, that is very debatable topic. So if the tumor nodule size is more than 5 mm and there is no fuzziness, there is no calcification within the node, and there is no background history of fever or something, then we can take that nodule as a suspicious for metastasis. And usually the lung metastases are more of a peripheral. They can be varying size, they can be solid, but they will have a very sharp margin as compared to the infection or other nodules. So in that way, we can partly differentiate between the lung nodules from inflammatory or infective cause versus metastasis. Here is a patient who had also this kind of mediastinal adenopathy and bony lesions. So when you see this kind of bony lytic areas, bony metastasis and lymphadenopathy in mediastinum, that is not a usual feature of the Wilms tumor. So when you see this kind of conglomerated finding, then you should think that this patient might be harboring other malignancy, and those kind of lesions should be biopsied. And this came out to be a clear cell sarcoma of the kidney. So one of the important features that when you see bony metastasis, that can be a red flag that this could not be a Wilms tumor, this could be something else also, because the percentage of the bony metastasis in Wilms tumor is around 1.3 or less than 1%, which is not that common. Here is one case scenario in which the child has presented with 4 months and swelling in the right lumbar region. Now, if you see here that it again looks like Wilms tumor, heterogeneously enhancing and expansile mass lesion, but the age is not favoring towards Wilms tumor. And this came out to be a mesoplastic nephroma. So the mesoplastic nephroma has two types. One is the classical variety, which has more homogeneous appearance. Another one is cellular variety, which has this kind of areas of necrosis, hemorrhage, which can almost mimic like a Wilms tumor, and that we cannot identify on imaging. So in this kind of scenario, age should strike you that this could be something else like mesoplastic nephroma. Here is the example that we came across recently. Again, the age of the child is 1 year, and the child presented with vomiting. And on imaging, we could found that there was a well-defined exophytic and expansile round-shaped lesion, which was arising from the middle aspect of the left kidney. But we could also see that there were multiple this kind of peripheral hypodense nodules were there in the left kidney also. And after that, the child developed some sort of some neurological symptoms, so that MRI was done, and MRI showed.
ते सांगितलं ना मी कालच ते बोलले आता वापरले तर नाही तर मग एफडी केली तर तुम्हाला
So combining all this all finding, we could this could be a rhabdoid tumor arising from kidney, and that had this kind of brain tumor also. So rhabdoid tumors are having association with the brain tumors. In this case, it was atypical terrible rhabdoid tumor in the brain. So connecting dots and carefully look at the history and other features really helps us that this could not be a Wilms tumor. Now the important topics that comes to that everyone should know, that how to differentiate a Wilms tumor from the neuroblastoma. So the Wilms tumor will have classical this claw sign that we already mentioned. As compared to the neuroblastoma, they will displace the kidney. Here we can see that the kidney is displaced as compared to this case in which the lesion itself is arising from the kidney and it is forming a claw. The neuroblastoma will also have this kind of spinal canal extension. As we can see that there are some calcific foci within the lesion, and that is also seen in the spinal canal component. So that is also commonly seen with neuroblastoma as compared to Wilms tumor. Calcification is more common in neuroblastoma as compared to Wilms. So these are some differentiating points which I have not the interest of time. Then one more important topic is how to differentiate nephrogenic rest versus Wilms tumor. Can I request everyone to please mute yourself? Dr. Shubhangi and Dr. Vikram, can you please mute yourself? Can I request all of you to mute yourself, please?
मग काय तसं ते उद्यापासून बघायचं.
Yeah. See, the other important topic that everybody when the oncologist comes to us that how to differentiate nephrogenic rest versus the Wilms. So the answer is not straightforward. No single imaging finding can fully differentiate between the nephrogenic rest versus a small Wilms tumor. But the literature says that if the size of the tumor is more than 1.75 centimeter, and if the age of the children is less than 5 years and the lesion is exophytic, spherical in shape, that will favor more towards Wilms tumor. And there are certain differences between the perilobar nephrogenic rest versus the intralobar nephrogenic rest that will be seen in the subsequent slides. So here is the example of intralobar variety of nephrogenic rest. So the intralobar variety is more of a heterogeneous. It can have tiny cystic area as well, and they are more prone for the propensity to convert into the Wilms. So this was the example of nephrogenic rest, which is seen on MRI. And now we'll go ahead to the lesions which are seen on both sides and which are predominantly solid in the pediatric population. So here is the example of diffuse perilobar nephrogenic rest, which is diffuse nephroblastomatosis, in which we can see that there is a circumferential rind-like hyperintense soft tissue which is infiltrating the bilateral kidney. And if you see in this very young age group, then you can think of that this is an example of perilobar nephrogenic rest, which are more homogeneous as compared to the intralobar rest. Here is the CT appearance of the perilobar nephrogenic rest, which are having this kind of multiple nodular appearance. And the same patient, one of the nodule had converted into this kind of Wilms tumor, which showing markedly expansive size and necrotic areas within it. So we are talking about bilateral renal tumors. Here is one of the case that we had solved at our institute. A 1 year, 7 months old girl child who had come with some orbital symptoms also. The child had bilateral corneal opacity, and the child was diagnosed previously as a Peters anomaly type 2. So I'm showing this because this is one of the syndromic association with the Wilms tumor. And what we saw that this patient had bilateral Wilms tumor. We can see that this is the right kidney Wilms tumor and that is the left kidney Wilms tumor. The left-sided kidney tumor was crossing midline also. This showing the midline crossing is very important because that makes the surgery difficult. So the surgeon should know that is there any midline crossing is there or not. And we also could see this kind of peripheral fairly homogeneous areas of hypodensity, which was looking like nephrogenic rest in the right kidney upper pole area. So this was the case example of bilateral renal Wilms tumor with this kind of nephrogenic rest. In this kind of scenario, the biopsy should be done. And of course, we have already mentioned that vessel assessment can be done on CT, so I'm not going to detail about this thing. Now, Dr. Kirti already said that biopsy, there are certain indications. Whenever like you see a lot of calcification within the mass, or you see voluminous adenopathy, markedly enlarged adenopathy, which can be seen sometimes with the lymphoma or some other disease process. And if you are not at all able to see the renal parenchyma, and if you see that the mass is almost extrarenal, then you should do biopsy. Now, doing a biopsy from the retroperitoneal route doesn't upstage the renal the Wilms tumor staging. That we have to know, and we should do always biopsy from the back side, from the retroperitoneal aspect. We should not go from the front side, just to prevent spillage into the peritoneal space. This is the patient which had Peters anomaly, and we are not able to see the lens also in this child. So that was the initial presentation, and then after chemotherapy, we can see that the size of the bilateral renal masses have reduced in size. Now, here is another example of bilateral renal masses with some different etiology. So here the age of the child is slightly older child, 6-year-old child who came with low-grade fever and constitutional symptoms. And what we can see here that both kidneys are looking like markedly expanded, and it looks like it shows very minimal to mild enhancement, but it looks like that something has infiltrated the kidney both bilaterally. And if you see carefully that even the bowel loops are showing this kind of circumferential wall thickening, which also shows mild enhancement. So when you see this kind of diffuse process and multiple organs involvement, then you should think always lymphoma as a possibility. And you can see that these are the coronal views, which shows that bilateral nephromegaly and diffused bulky hypoenhancing masses, which are almost replacing the normal parenchyma. And this is the circumferential wall thickening, which is seen in the bowel, which shows the same process, lymphoma process in this child. And not all lesions are neoplastic that I wanted to highlight. So here is one child, 8-year-old child who was referred for bilateral renal lesions. And what we saw on ultrasound, that first thing is that both the kidneys were shrunken in size. And the patient has past history of recurrent UTI and febrile illness. And there was loss of architecture, like differential between the cortex and medulla. And on the high frequency probe, we could see that the patient had this kind of multiple nodular lesions, but the vascularity was normal in that location. It was not causing splaying of the vessels, and there were multiple this kind of hyperechoic nodules. We also did, these are the CT outside films. Pardon me for the poor resolution of images. We also did MRI to characterize further. And so these lesions were slightly more brighter than the normal parenchyma on star and T2 weighted images, but they were not showing restricted diffusion. So usually Wilms tumor or any malignant tumor, they should show restricted diffusion. So that's the advantage of doing MRI. MRI has this kind of special techniques like DW and certain sequences which can help us to assess the cellularity, which can be additional benefit when we are dealing with this kind of difficult cases. And in this case, there was no restricted diffusion. And considering the background issue of passage of UTI, and the patient also had postureuretral valve. So we thought that this all is most likely a pseudotumors which has arisen in the chronic kidney disease, which are basically nodular hypertrophy of the dysplastic parenchyma, which can happen secondary to long-term infection or secondary to like multifocal scarring. In that you can see this kind of nodular hypertrophy. So these are not neoplastic process, and you should not take out the kidney in this kind of scenario. So finally, to conclude, key imaging features, they will help us to guide the surgery, and they will impact the tumor staging, and they will determine the need for preoperative chemotherapy. And we should be aware about differences of the unilateral and bilateral solid renal masses and their peculiar imaging features or age and clinical presentation that can raise some red flags that this could not be a Wilms. And your initial imaging should include contrast enhanced CT chest. And for abdomen and pelvis, you can do either CT or MR, whichever is preferable. And the surveillance of the tumor should be done for the first 2 years, because that's the time the maximum risk of recurrence happens. So by that, I want to conclude my session. Thank you for attending. Yeah.
Thank you, Dr. Hirin. Our next speaker is Dr. Shefali Jadhav. Dr. Shefali is a junior consultant at SRCC Hospital in the Department of Pathology. She has special interests in hematopathology and pediatric pathology. Over to you, Dr. Shefali.
Thank you, Dr. Rujul. Sorry for the delay. I'll be taking over the pathophysiology of Wilms tumor. Okay. Nephroblastoma is one of the common malignant solid extracranial tumor of childhood, and it has one of the major success stories in pediatric oncology. It is slightly more common in girls and more than boys. The median age in boys is 36 months compared to girls, which is 42 months. It is really uncommon in neonates and infant, and it is an occasionally reported in adults. Most cases of adults are primitive neuroectodermal tumors, synovial sarcomas, or metanephric adenomas. The major emphasis has been on accurate histological diagnosis, which helps in risk stratification, tailored surgical resection, and timely radiotherapy and chemotherapy. So my colleagues have already taken regarding the Wilms tumor clinical features and what other syndromes are seen. So 5% of the cases are bilateral, with bilateral tumors are most likely to be associated with nephrogenic rest. A positive family history is found in 2% of patients with WT. The slide looks scary, but it is also important. It's the molecular and cellular biology of Wilms tumor. Okay, WT1. It is the first genetic locus which was identified in patients with Vagus syndrome, which carries a 30% risk of developing Wilms tumor. Abnormalities with WT1 are consistently found in tumors of Vagus patient as well as patients with Denis-Dos syndrome, which carries a 90% risk of nephroblastoma. WT1 expression is found primarily in the urogenital system. So in adult, WT1 expression is found in the urogenital system, the central nervous system, and in tissues involved in hematopoiesis. So this gene is located in P13 region of chromosome 11. It encodes a zinc finger DNA binding transcription factor that is essential for normal genitourinary development, and mutation and deletions are found in 15% of the sporadic cases. Basically, the uncontrolled growth of cancer cells can be due to either a loss of a tumor suppressor or an activation of an oncogene. But there are opposite function can be there due to a mutually exclusive for a single protein, evidence which is emerging one of the protein that can exhibit both properties. One example is an oncogene MYC1. WT1 also has a similar dual expression depending on the cell type in which it is expressed. Moving on to WT2, it is a second locus which is seen on 11p15. It is associated with Beckwith-Whitman syndrome, which carries a 5% risk of developing WT. So FWT1 and T2, approximately 2% of Wilms tumor have a family history of WT. Familial WT Wilms tumor cases generally have an early age of onset and an increased frequency of bilateral disease. However, some can also display a later age of diagnosis. So these genes are located at 17q12 and T2 is 19q13. WTX, it is generally recently gene, and still more work is going on. It is located on XQ11.1 and named as WTX, which is inactivated in Wilms tumor. WTX inactivation appears to follow a one-hit hypothesis, since male only have one copy and female only need to lose the copy of active X chromosome. It's supposed to participate in the WNT signaling pathway and to promote the ubiquitation and degradation of B-catenin. And moving over to P53, which is located on chromosome 17p, is thought to play a role in subset of patient, and the high correlation is associated with an anaplastic phenotype. Loss of heterozygosity 1p, 11p, and 16q, and in that 1p and 16q is an adverse prognostic factor. High telomerase expression is also an adverse prognostic factor in favorable histology of Wilms tumor. The presence of loss of heterozygosity for chromosome 1p and 16q help in risk stratification, which is commonly seen in the COG protocol. So what are nephrogenic rests basically? The nephrogenic rests are abnormal persistent foci of embryonal cells which have a potential to develop Wilms tumor. They are encountered in 25 to 40% of Wilms tumor and in 1% of a routine postmortem examination seen in infants. They are perilobar and interlobular. They consist variable amount of blastomal, epithelial, and stromal component, which is also seen in Wilms tumor. The ones which are show no potential to Wilms tumor development may be dormant, sclerosed, or hyperplastic. Majority regress and become fibrotic, and some give rise to Wilms tumor with the remnant of nephrogenic rest visible at the periphery of the neoplasm. Nephrogenic rest are seen 40% in unilateral and majority in bilateral. As you can see in this picture, the perilobal is generally associated with WT2, epithelial and blastomal, and intrarobular will also WT1 more, and it is stromal predominant or mixed. So as you can see here, this is a nephrogenic rest in a normal identified kidney where you can see glomerulus and other tubules. So this is in short how a normal kidney development takes place and what happens in Wilms tumor development. The metanephric blastomal cell persists and it grows into nephrogenic rest, and depending on the genetic and epigenetic change, it either remains dormant or it changes into adenomatous rest. And genetic and again epigenetic change in a dormant, it can be neoplastic and hence further proliferation. Here you in a short umbrella type of this, you can get a overview of what are the mutations which can be seen. So the gross, basically these are very large solitary spherical mass sharply demarcated from the renal parenchyma. The bulging surface is generally pale gray, soft, friable and lobulated, along with areas of hemorrhage and necrosis is seen. One should also see whether in the renal vein, whether it has a tumor deposit or not. One has to see all the tumor margins is properly or not. We can also see few cystic appearance. For example, this is a pre-treated case where you can see foci of hemorrhage. They are nodules and each nodule is separated by a pseudocapsule. And there are hemorrhagic nodules, and as you can see at the lower pole, it's a compressed kidney. And on this, you can see a nodule which is trying to penetrate the capsule. This is not given any chemotherapy with an upfront surgery. As you can see, it is fleshy. There are no necrotic or hemorrhagic nodules. It's a huge fleshy mass which is surrounded by a pseudocapsule. This was a tumor deposit which was found in there is tumor deposit at the renal vein. This was a tumor deposit seen in the atria at an autopsy. So the grossing of Wilms tumor. So a section back, like a whole section is taken and grids are made. So this is very important, as these are also is mentioned in the report, like what type of specimen is received, whether the hilum of the kidney is seen or not, whether the kidney, whether the mass has distorted the hilum, whether the kidney is seen, adrenals are seen, whether the gyratosphagia is intact or there is breached by the tumor, whether, and all these things like renal hilum, renal sinuses, vein invasion, and resection end of ureters, all these things has to be noted and also mentioned in the gross report. These are the common lymph nodes which are basically sampled while surgery, which are hilar, aortocaval. Okay, so these are the array of slides which come after the resection, after the grossing of a specimen. So on microscopy, this is a microscopy image of a image-based biopsy, which is on low power view. One can see these tubules, one can see hemorrhagic nodules, and at places one could also appreciate the mesenchymal component. So these are the hemorrhagic nodules which you can see, which are very poorly differentiated. They are nowhere forming rosettes. These are the tubules, the three components: blastomal, tubules, and the mesenchymal component. The tubules, depending upon differentiation, can be poorly, moderately, and well differentiated. So this is a low power view of a blastomal predominant Wilms. As you can see, nowhere you can see any tubules, nor you can see any mesenchymal component. And these are just nodules and nodules of this blastomal component. These look very similar like an undifferentiated round blue cell tumor. The anaplasia. In our reporting, we also have to mention whether we could appreciate any anaplasia or not. So a focal anaplasia or a diffuse anaplasia. So these are the points which needs to be covered. Like these three features, like if it is enlarged, atypical, tripolar, multipolar mitotic figures, marked nuclear enlargement, and hyperchromochromasia. If all these three points are found satisfactory, it is termed as anaplasia. So these are the few post-chemotherapy changes which can be seen, like pigment deposition and necrosis with inflammation. So this is a summary of a report which is there, which is whether which side, favorable, unfavorable, anaplasia present, vascular invasion, tumor invades the renal capsule, not invades renal sinus involvement, hilar lymph nodes seen, foci of nephroblastosis was seen or not, resection margins, whether they were clear or not, and if an adrenal is seen, whether it was seen or whether it had any tumor deposits. So here I'm mentioning PSYOP, which will also be talked about by my colleagues, because in most of our cases are pre-treated cases, and for that we generally give this classification: low risk, intermediate, and high risk. As you can see, low risk are the one which are completely necrotic nephroblastoma, and in intermediate risk, here you can see with all, depending on the type of chemotherapy induced change and the viable component, these are segregated into regressive, mixed, epithelial, and plastimal. Once again, I'm just taking you to the class risk, low risk, intermediate risk, and high risk as per the each protocol. Again, this staging which was taken by my previous colleagues. So just to complete on Wilms tumor, wanted to say about IHC. IHCs is not generally required. It's required only when there is a core biopsy and it is blastomal predominant Wilms tumor, which you need to prove. And the most important marker which is used is WT1, which is sensitive and specific, and it is used for blastomal and the epithelial component. So these are these nuclear and cytoplasmic WT1 IHC showing mets in the lymph node. Thank you.
Thank you, Dr. Shefali. Our next speaker is Dr. Chintan Vyas. Dr. Chintan Vyas is a full-time pediatric hemat-oncologist, immunodeficiency and BMT consultant with an experience over 10 years. He's performed over 200 pediatric bone marrow transplants to date. He's also experienced in pediatric cellular therapies like CAR for pediatric leukemia, lymphoma, and activated NK cell therapy for solid tumors in children. I'd hand over to Sir for the next topic on chemotherapy for favorable histology. Dr. Chintan?
Yeah, he's joining in a minute. Just downloading the presentation.
Okay, sir. Okay, sir.
This have to be removed.
Share karo. Share.
Slide full screen.
Thank you very much, Dr. Gul, and thank you, Dr. Asik and team at SSC for organizing this wonderful CME. So as of now, we have learned about the diagnosis. As of now, we have learned about the way to diagnose, how to differentiate between the renal, non-renal, non-malignant renal masses, malignant renal masses. Dr. Hirin has quickly highlighted. Then we also learned about the clinical presentation, which Dr. Kirti has highlighted, and Dr. Stefani has given an overview how to report and how to read the report, which is one of the most difficult part from the clinician side. Now, what my job is to me and my successor, Dr. Chira's job is to tell you about the treatment. Now, the treatment for renal tumor is divided in between three types of physician. One is chemotherapist, which is oncologist. Second is surgeon, which Dr. Rasid will highlight. Sir will highlight about the different modalities of surgery. And the third is radiotherapist. Now, when we talk about the chemotherapist or the oncologist, medical part or pediatric part of the oncology, we decide how to treat this tumor based on certain factors. Now, we have already learned the histology that the Wilms tumor is classically triphasic tumor where there is a three-component blastomal, stromal, and epithelial. And blastoma is a differentiated small round blue cell tumor. So, Wilms is one of the small round blue cell tumor out of few. So, when we see a lot of small round blue cell tumor in a young child with the renal mass, definitely the Wilms tumor is one of the most important diagnostic, one of the most important differential diagnosis. Other component is stromal and epithelial. Now, when we differentiate the tumor between the favorable histology, which I have to talk about, versus the unfavorable histology, which we will hear in the next lecture, how will we say that the patient is having favorable histology and how will we say the patient is having unfavorable histology? So, as Dr. Shefali has already highlighted, that the anaplasia has to be reported whether it is there or not and what type of anaplasia it is there. Because on basis of anaplasia, that is the single most important marker to differentiate whether the patient is having favorable histology or unfavorable histology. Another very important part is what you see in terms of the blastomal cell morphology. And what are the percentage of blastomal cells in your pre-chemotherapy operated tumor or a post-adjuvant neoadjuvant chemotherapy operated tumor. So how will we define the anaplasia, which Dr. Shefali has already told and explained to us? Then you have to have 3 times higher the nuclei, hyperchromatosia, multiple mitotic figures. You in the anaplasia also you divide in focal and diffuse, and the reason why we divide in focal and diffuse because focal is also considerably not so poor and considered as a lower intermediate risk histology. While you have a diffuse anaplasia, means if you have anaplasia even in the extrarenal site, if you have an anaplasia in a random biopsy sample, if you have an anaplasia unequivocal in one region of the tumor with extreme nuclear unrest elsewhere, or if you have anaplasia with more than one tumor slide from different regions. So these are the 4 categories in which we tell that the patient is having diffuse anaplasia. Versus if you have a well circumscribed anaplasia and not extended in the external side, which is focal. Now, why we stress upon all these things are important in terms of the histopathology report? Because if you see that patient is having with anaplasia, straight away it is a high risk histology or unfavorable histology versus without anaplasia as per the Americans. When we talk about what follow Europeans, so Europeans has slightly different way of categorizing this histopathology, and they categorize in low, intermediate, and high risk. And how do they categorize, which we have already learned in the previous class. I am not going to go into detail. This slide has been already shown to you by the previous speaker. But most important thing that the blastomal predominant histopathology, even after receiving few cycles of chemotherapy, particularly if it is more than a third of tumor having blastomal predominant, it is not a good sign. That means your tumor is not a low risk tumor, it is a high risk tumor. Now, again, what are the other prognostic factors which will define the risk stratification? One thing I talked about is histology, second is staging, which already has been described, age, which has been re-emphasized multiple times, that older age or an infant, they do fairly not very good compared to the classical age of Wilms tumor. And other molecular markers like LOX16Q, 1B, gain of 16Q, and increased telomerase expression, which also been told. What are the treatment options? It has to be a multimodality treatment option. One person cannot win the race. It has to be oncologist, with a good surgeon, with a radiotherapist where it is being needed. So chemotherapy is for all cases, surgery is for all cases, and radiation in the selected cases. Two major groups which we have learned through till date. What I will just go through the basic approach, because that is the only thing which has not been talked about in detail, that what Americans follow and why they follow, and what Europeans follow and why they follow, and what we Indians follow. We always do Margi. So what Americans follow is that immediate nephrectomy. They have good surgeons, they are confident in removing the tumor upfront, they do immediate nephrectomy, except some indications where they also reserve the surgeon for a later date and do the chemotherapy. So what are the advantages of following American approach? You are administering chemo not to the benign disease, because you are very sure that you have whatever you have operated is a malignant pathology, and then only you will start the chemo. Second, you can get accurate staging because you will not have a reduction in the size and then the staging will change. So you will get accurate staging by following this American approach. But the most important problem with this approach is that you have a tumor spillage, and we do not, the surgeon's approach to the tumor is also not unanimous, and it is sometimes difficult also for the surgeons not to prevent the tumor spillage, and that the tumor spillage is very bad. If it happens, it has to be upstaged to stage 3 straight away, and the patient has to receive the abdominal radiation in that case. What Europeans follow, they follow do not operate upfront, give some chemotherapy. Advantage of that is reduce the chance of tumor spill, and response of the treatment can be evaluated because you have given some chemotherapy. Disadvantage is that you may alter the biology of the tumor because you have given some chemotherapy, and you may very, very rarely, but end up giving chemotherapy to a benign disease, which practically I have not seen, because our radiologists and our surgeons and we with experience have a good way to say that this is a Wilms tumor. If we are in doubt, we always do the biopsy. We do not treat with chemotherapy and non-malignant disorder. But arguments against disadvantage is that the newer histological groups can be assigned based on the post-chemo changes, which I have already shown in the previous slide. And the use of anthracycline and radiotherapy can be restricted to those with inadequate response. So again, who wins the race? Nobody wins the race. It's all about what your institute is good with. So tumor histology can be accurately dealt with an American approach, but spillage can be prevented with the European approach. You may end up being less treating with American approach because you have removed tumor upfront, and you may be treating more with the European approach, which most of our centers also follow in India. And the response of chemo can only be evaluated by Cyclophyr approach. Surgical complications definitely more in the Cyclophyr approach, which is a European approach. But we have to take what is good for our patients. No clear advantage, debate still continues. But some factors like tumor size, patient's clinical condition, and experience of surgeons are the dictum to do one versus another. Now, what are the chemotherapeutic options? Whether it is low risk or high risk, we have all these limited drugs options. So we do not have hundreds of chemotherapy or not a fancy molecular targets for this tumor still, which is now 70-year-old in terms of the first chemotherapy was invented for this tumor in 1950 odd, and still we are dealing with these 5 or 6 type of drugs. Vincristine, actino, and doxorubicin. VAD is the backbone of Wilms tumor treatment, followed by some additional agent which Dr. Chira will highlight when she will talk about the high-risk chemotherapy like cyclophosphamide, etoposide, some platinum-based components, and some chemotherapy which we need to use for the relapsed refractory setting. Now, I won't go into the details of trial, but as we can see, the trials have been started since 1970s. Every 5 years there are new trials, and every 5 years there is new publication, which we now also get tired of reading. But if we see that the latest trial is 2001, and the basic approach is that when you have a favorable histology and a limited stage disease, which I have told, that if you have a limited stage disease means if you have stage 1, which is completely operated or limited, localized, no breaching fascia of aorta, no renal vein involvement, no lymph nodes involvement, lymph nodes are biopsied and negative. So those are the stage 1 disease and no pulmonary metastasis. So these with any histology or stage 2 with a favorable histology, the chemotherapeutic agent for a post-operative regimen is 18 weeks. This presentation is not showing. So
Thank you.
yeah, so there's some part which is missed, I think, probably because of the changing format of the presentation. But what I was just highlighting that yeah. So what I was going to show in this picture was basically a 3-drug regimen: actinomycin, vincristine, and doxorubicin, and this is usually go on for 24 weeks. So post-operative, the regimen is for 24 weeks. Pre-operative, the regimen is for 4 to 6 weeks, depend on what stage you are dealing. If you are having stage 4, you have the third drug, which is doxorubicin, involved. And if you are dealing with a limited stage, which is stage 1, 2, or 3, and not having pulmonary metastasis, you give vincristine, actinomycin. So this is a pre-op, but the post-op treatment, which usually consists of 3 drugs, which is vincristine, actinomycin, and doxorubicin. Now, doxorubicin is one of the drugs which we use very carefully in our setting because it has a anthracycline-related toxicity, particularly heart toxicity, so cardiac toxicity. And it can present immediately during the infusion, 48 hours later, or it can present after 6 months or a year after a chemotherapy. So the anthracycline use has to be very targeted, limited, and we have to be very careful not to use more than 300 or 350 milligrams per meter square of dose of anthracycline, and to screen in between at every 100 milligrams per meter square dose, or let's say if you are crossed below after 200, you have to screen very carefully with your heart function and restrict your use of anthracycline before your heart gets damaged. So the third drug, doxorubicin, we use very carefully. Usually in this regimen, it has been used 4 times. 50 milligram per meter square means 200 milligram per meter square. So if you see the treatment summary, I'm very sorry for this, but I don't know why the tables are not been seen, or the graphical figures are not been seen in this presentation. But if you see the outcome of NWPS5, the Wilms tumor is such a tumor, even with a stage 4 disease, which is a pulmonary metastasis, you have an outcome of 75%. 75% outcome with stage 4 disease. But the caveat is here, you have to see what is your histology. If you have a favorable histology, outcome is 75%, even in the metastatic setting. But if you are having an unfavorable histology, like anaplasia, your outcome goes down to 30%. So that is the importance of favorable versus unfavorable histology. New risk stratification, particularly LOH, loss of heterozygosity of 1P and 16q, which we do define in our molecular distribution. Although in India, still not, I would not say centers are doing this, because we still have a limitation of molecular marker analysis, and that's why we are not banking too much on LOH, 1P and 16q. We go for the morphology and histology, and then we subsequently decide our treatment. Now, this a very important part, which Dr. Asif will also highlight, that that very low risk and standard risk favorable histology. In this patient, let's say if you have a stage 1 disease and if you have completely removed the tumor, people say that you may not need to give chemotherapy also, no role of radiotherapy if your histology is low risk, and you can just observe, particularly the tumor who are less than 550 gram and stage 1 disease. And what they have noticed that some of this tumor may have relapsed, but eventually the overall survival remains the same. So in between the trial, we thought probably we can't stop this patient not giving chemotherapy, it's malignancy. But then later on realized that the trial was stopped and the reanalysis was done at the 2 years of the trial, and then they found that overall survival remains unchanged. So very low risk, very low burden tumor, very low in the size, and younger than the 24 months, we can still think without using the chemotherapy. Now, this is the indication where we can just do nephrectomy and treat without chemotherapy if you have a younger than 24 months of age, stage 1, and less than 550 grams of tumor. Now, what we follow in Indian setting is a SIOPR approach, and in the SIOPR approach, because we do not have sometimes always availability of a good surgeons who can confidently remove the tumor without having significant tumor spillage, so we most of the times end up using the pre-operative chemotherapy, which is a SIOPR approach or a European approach. And in that also there are 6 trials now, and then again it ended up being an umbrella trial which they have merged with American and European protocol. And as per the latest trial, we again use 2 drugs in a non-metastatic setting and 3 drugs in a metastatic setting in a pre-operative regimen, and 3 drugs in otherwise non-metastatic staging in a favorable histology, and 4 drugs in an unfavorable histology or metastatic setting. Again, the molecular marking, we do not have that much facility, but yes, if they are present, it does define the poor prognosis. Now, again, this chart is not showing, but here I want to just emphasize that doxorubicin, the addition of doxorubicin in particularly intermediate risk intermediate risk Wilms tumor is still a question mark, and the use of doxorubicin has been debated in an intermediate risk stage 2 or 3 in a post-operative setting, and overall survival they are found equal without doxorubicin also. So some of the stage 2 or 3 intermediate risk histology patient may be benefited, and that was the main purpose of SIOP 2001 trial, that can we omit this cardiotoxic regimen from an intermediate risk pathology stage 2-3 patients, and they have found that we can omit. Now, last 5 minutes I'll just speak on the pulmonary metastasis. And here the beauty of the situation is that even if you are having metastasis, you may not be always a bad histology. So one, you have metastasis, but you may have a good histology of the tumor. So in those cases, what you will do? So what Americans do, they use the CT scan to confirm the metastasis and give whole lung radiation. But what the Europeans do, they assess after the preoperative and some courses of postoperative chemotherapy, and they try to resect the nodule. And if the nodule is if it is persistent, then they try to resect the nodule and then see what is a tumor in that nodule. Now, what we will do, if you think that you are following the pre-surgery, when you are following the surgery and then chemotherapy approach, which is a COG approach, then you will assess at the end of 6 weeks, and then you see whether your pulmonary metastasis after doing the surgery is still there or not. Well, you have done the chemotherapy, you have done the surgery. After surgery, you have given another chemotherapy post-operative for 6 weeks. Then you reassess. If your tumor in the lung is still there, you try to resect if it is possible. And if it is not possible, then you continue a few more cycles of chemotherapy and then try to resect. But let us say if your tumor is disappeared and in your surgical specimen, the histopathology is a favorable risk pathology, then you continue to use 3 drugs and do not have to use high risk protocol, which Dr. Uchida will be talking about in a high risk setting. And you can limit your post-operative chemotherapy to 3 drugs to maybe 27 weeks. Yeah, but if you have any kind of tumor which is positive or your pulmonary metastasis has not disappeared, then you definitely upstage your disease to 4-drug regimen, which includes cyclophosphamide and etoposide. And this is the same thing which COG also follows. They also follow because they do also the LOH1P and 16q. The only caveat which they have added that if you have, apart from bad histology, if you have any kind of loss of heterozygosity, then also you use 4 drugs and do not just limit your post-operative to 3 drugs. So the timing of metastatictomy post-operatively is important. Assessment by doing CT scan after 6 weeks or 10 weeks is important, and then you decide whether you have to use 3 drugs or 4 drugs. So this is all what I wanted to talk. I'm sorry for not able to see the graph, but I think what message I wanted to share, maybe you have understood. And subsequent topics maybe Dr. Nishra will further highlight about how we approach the high risk histology, and Dr. Asif will tell you about how to do the surgical management. So thank you very much, and I'll hand over to the next guest. Thanks.
Thank you, Dr. Chintan. Our next speaker is Dr. Ruchira Mishra. She will be talking about chemotherapy for unfavorable histology. Dr. Ruchira is a senior consultant in the Department of Pediatric Hemat-Oncology and BMT at SRCC Children's Hospital. She has completed her MBBS from Kanpur University with a distinction in biochemistry and has done her DCH from LLRM Medical College, Meerut, followed by DNB Pediatrics from Bombay Hospital. She then pursued pediatric hemat-oncology and BMT training in Australia and worked at Brisbane, Melbourne, and Sydney. She was further trained at the Children's Hospital in Westmead, Sydney, Australia, in pediatric oncology and earned a specialization in BMT. Over to you, Dr. Ruchira.
Resume share.
Good afternoon, everyone. I hope that you are being able to learn something from this masterclass that we are holding today for women's tumors. We have so we've been talking about women's tumors, and that's okay. We'll just carry on with this. What we will do is we learned how a women's tumor presents, which is most important for general pediatricians, because that's what you will be able to. You are the ones who will see the patient, suspect women's tumors, and then be able to refer them for the appropriate management. We've seen how to stage the disease. We've seen
speaker. Arrow पे click करना. नीचे arrow से लेना पड़ता है.
we've seen how you diagnosed or suspected wounds. You refer them for investigations. We've had a biopsy or maybe an upfront surgery for this nephrectomy that's been done, and how we've made the diagnosis of a women's tumor. Now arises the question of how are we going to be able to treat them. To be able to treat a women's tumor, you really need to know exactly what is the histopathology, which people like Dr. Shifali would be able to guide you and give you a proper idea. And you would have to know what the radiologist has told you about the staging of the disease as well. So with this idea, we will then work on to define the treatment approach that we will take to manage these patients. We've already learned what favorable histopathology is, which is the majority part of women's tumor and which is why they have such a good response to treatment. But now we will delve into the smaller aspect, which is the unfavorable histology. And the reason why we call it unfavorable is because they show a lesser response to chemotherapy. As Dr. Shifali mentioned earlier also, there are 3 histological criteria that have to be met to be able to classify them as unfavorable histology. Or when we say that they have anaplasia present, that is when they have nuclei that are enlarged to more than 3 times the size of their adjacent nuclei. There's marked hyperchromasia that is present, and there are multipolar mitotic figures. But as Dr. Chintan mentioned, that they can also be, there's this diffuse anaplasia, which is more important than focal anaplasia that is there. We usually see this only in about 5% of the nephroblastomas or wounds that we come across, and usually it is associated with a P53 mutation. So if you're finding diffuse anaplasia, then you should be looking for a P53 mutation also. The thing to remember is that you generally will not find it in children who are less than 2 years of age. And if it is a stage 1 tumor with anaplasia, then generally these wounds can also be bent a little bit. But remember that you need to diagnose anaplasia, you do need to have multiple samplings done for the tumor itself. Now, the other tumor that has an unfavorable histology is the blastemal predominant tumor that we see. When we classify it as blastemal predominant, we're looking at only the viable part of the tumor, and this viable tumor has to be more than 1/3 of the whole tumor mass that has been given to the histopathologist. And of this viable tumor, at least 2/3 of it should have the blastemal component to it. So therefore, it is 1/3 tumor more, 1/3 tumor, more than 1/3 tumor of the tumor mass, and of that 1/3, at least 2/3 should be blastemal before it is there. The other components of neuroblastoma that we have seen, the epithelium and the stroma, may be present in different this thing. Also remember that this blastemal predominant category comes only if you treated them with chemotherapy upfront, not by those where they have done a primary nephrectomy. So the blastemal predominant does not become an unfavorable histopathology with the NWTS or the American approach, where you've done an upfront nephrectomy. It only becomes unfavorable histology if the patient has been given some chemotherapy before the nephrectomy was done. There are two more criteria that you need to look at, which is clear cell sarcoma of the kidney and rhabdoid tumors of the kidney, which do not do very well and are not very responsive to our management, and therefore they are also classified as unfavorable histology. Staging we've looked at, so staging and histopathology both need to be looked at together, and that's when we decide how to treat these patients. So whenever we come at it, we have to look at the last bit, that is the unfavorable histology. These are the high risk group. Some people also, the present SIOP studies look at the tumor volume also to look at unfavorable histopathology. But when we decide to treat them, we treat them with a 3-drug approach, that is AVD. If you were listening to Chintan's talk, you would have realized what normally we're using 2 drugs, that is actinomycin and vincristine, which are very non-toxic medications that we use for brain tumors. But then we add doxycycline to the high-risk group as well. And that is where we use 3-drug regimen when we are defining this as high-risk categories. If you're looking at stage 2 and stage 3, just these 3 drugs don't work. We use something called as a high-risk chemotherapy arm, and we add radiation to it as well. The radiation aspect will be covered at the end of this lecture series as well. If you have a stage...
Excuse me, ma'am.
Yeah.
Sorry to interrupt you, ma'am. I can't see the slides. It's just stuck on the first slide itself.
We'll start again. Can you see us now?
Now it's better, ma'am. Yes. Thank you, ma'am.
Thank you for pointing that out, Dr. Priyanka. So, when we define the treatment approach for unfavorable histology of high risk, when we're looking at stage 1, we're looking at the 3-drug regimen, it's AVD. But when we're looking at stage 2 and stage 3, we look at high risk chemotherapy and radiation with it. When we're looking at stage 4 disease, which is also classified as high risk disease for us, instead of giving the 4 weeks of 2-drug regimens before surgery in SIOP, we generally give them a 6-week regimen of 3 drugs, that's AVD. Do a surgery and a metastectomy, and then define as to how we will treat them later on. Stage 5 or bilateral wills is a different entity altogether, and we will treat them very separately as well. So what is the pre-op chemotherapy? It's a 2-drug regimen we generally give for 4 to 6 weeks. When you're looking at high-risk disease, then you kind of put it to 6 weeks, but otherwise you give it for 4 weeks and then plan for a nephrectomy in these patients. As we discussed, high-risk local stage 1 gets AVD, but stage 2 and stage 3 will get high-risk chemotherapy. Treatment generally in the AVD regimen is planned for about 26 weeks. And these 3 drugs are given at different time intervals, usually initially at weekly intervals, and then later on we kind of space it to give more like a maintenance of consolidation therapy for these patients. However, remember that it is about at least 6.5 months of treatment that is being given. When we're looking at high-risk chemotherapy, we don't use vincristine, actinomycin, and doxorubicin, but we use stronger agents like etoposide, carboplatin, cyclophosphamide, and doxorubicin. But as again, what was mentioned by the previous speaker, we try to cap the doxorubicin at around 30 milligrams per meter squared in these patients. The treatment here now continues for about 34 weeks, which is about 8.5 months of treatment that is being given. We will have to dose adjust based on the weight of the child, based on the nutritional status of the child, and also if there is radiation coming in as well. Whenever we look at metastatic disease, we again say that we do a 6-week preoperative surgery, preoperative chemotherapy. The surgery will involve both local resection of the tumor as well as metastectomy. When you look at metastectomy, and if we manage to get rid of the complete tumor or the metastasis has disappeared by the 6 weeks of therapy, then we will stage them as per the local stage, and we give them a 3-drug regimen treatment. But if they are stage 3, then we will add radiation to our treatment arm as well. However, if your metastasis could not be resected, then we will, in stage 1 and stage 2, we will shift to the high-risk treatment arm, try and avoid abdominal radiation if we can, and again evaluate the status of the pulmonary mets. So if we can achieve remission with the pulmonary lesions, then we do not offer radiation to lungs. But if we cannot achieve remission, then radiation has to be included in our management protocols. Stage 3 tumors will always get abdominal radiation with them as well. Why do we need to do all this? Because while we're talking of very good survivals with our stage 1, stage 2 disease with favorable histopathology, event-free survival for diffuse anaplasia is not as good. However, if you are looking at stage 2, it is still about 80%, that you can look at here. With the survival numbers kind of decreasing as the years go past. So 17 in this study that was published in Journal of Clinical Oncology, from 17 children who were surviving at 2 years, the numbers that were surviving at 6 years decreased to 7. With stage 3 disease, again, the kind of numbers do keep going down. However, we still have survivals that are about 65%. It's the stage 4 where you have upfront surgery, you don't have that good a response, where the response is less than 40% of patients in this category. Now, this is treatment that is being based on the SIOP approach, which says give chemotherapy for your high-risk tumors upfront. However, what happens if we've done an upfront nephrectomy? Say somebody came in and we did the nephrectomy and then realized that we were dealing with a high-risk neoplasm, a high-risk tumors. In diffuse anaplasia stage 1 to stage 4, usually we will shift to the high-risk postoperative arm, and we will give abdominal radiation to our stage 2 and stage 3. All of our stage 4, where we have lung mets, will also receive lung radiotherapy as well. So this is what we should look at. Now we come to the 2 other categories that we were also dealing with, which is the clear cell sarcoma and the rhabdoid tumors of the kidney. Again, clear cell sarcomas, generally we would prefer to give the 3-drug preoperative chemotherapy as we would do for a stage 4 tumor. And we follow the SIOP high-risk operative arm in these patients. These are tumors generally where we had a biopsy done upfront in these patients because they present at the extreme stage, not like a typical LIMS. And we will offer abdominal radiotherapy to stage 2, stage 3, or stage 4, but not to stage 1 disease. The malignant rhabdoid tumors of the kidney are a very poor risk group, usually presenting in under 2 years of age, usually associated with brain tumors as well, which was highlighted both by Dr. Kurkuri when she showed you the case where we recently diagnosed a child who came in with an abdominal lump, but first she had symptoms of persistent vomiting. We did a brain MRI and picked up the brain tumor as well. Treatment approaches differ. There is no unanimity on what should be done. SIOP generally recommends that we use an MMT98 protocol, but there are other protocols available as well. There's a Rhabdoid 2007 recommendation which uses high-dose VCB and ICE alternating with each other and then gives you maintenance therapy as well. Or the UK protocols which suggest, which is the UHAP consensus, which uses doxorubicin followed by ICE, vincristine, cyclophosphamide, BCA with radiation involved in them, and then also adds carboplatin later on to this regimen as well. A word about bilateral Wilms tumors, because that was one entity which hasn't been covered a lot. We know that bilateral tumors are seen more with children who have genetic predisposition, which we have already learned about. That is the VAGA, which is Wilms tumors, aniridia, genitourinary anomalies, and retardation, a Beckwith-Wiedemann syndrome, hemi-hypertrophy, or any other overgrowth syndromes. We almost, these genetic malformations or syndromes will be present in at least about 22% of the bilateral Wilms tumor series that we have. Always when you're looking at a Wilms tumor, remember that you have to look at the other side, the other kidney as well, because the nephroblastomatosis or multiple or diffuse nephrogenic rests can be present, and these nephrogenic rests are considered to be precursor lesions in these and may sometimes actually evolve and become a Wilms tumor, which one case was shown by Dr. Hirin as well in our previous lecture. These actively proliferating rests, which are called hyperplastic rests, they can sometimes look like a Wilms and sometimes can actually evolve and become a Wilms as well. So remember that you have to screen the other kidney as well. The tumors can be synchronous, that's presenting at the same time in both the kidneys, or they can be metachronous, where we present one after another. So just remember to do that. Treatment regimens are a little different. We have to stage each kidney separately and then we base our treatment. Usually we use a VAG in these patients for pre-operatively. Then the first assessment is done after 4 weeks, which is usually just an ultrasound. If we can find that there's a good response, there's a decrease in the tumor volume, we continue for another 4 weeks of the same chemo regimen. But if we find there's stable or progressive disease, then we have to add other medications to this, like doxorubicin is generally added later on. The second assessment is done at week 8. If there is decrease in the mass, then we think about surgery. And usually the surgery will involve maybe the nephrectomy on one side, which is more involved, and nephron sparing surgery, if possible, on the other side. So there is some renal tissue that is always there. It is followed up with chemotherapy, which is generally given for a longer time later on. The NWTS protocol, where there is upfront surgery, usually says that when you have diffuse anaplastic histopathology, you use a regimen called regimen I, which is very different from the EE4A or the DD4A regimen, which was used for focal anaplastic histopathology. So you add this regimen I. Again, in this case, you're using doxorubicin, you're using vincristine, but you're also adding carboplatin and etoposide to a regimen. And in the stage 2 to stage 4 category, you may also be looking at adding abdominal radiation to this. The reason why we put up these chemo regimens is not because we would like you to start taking active part in giving the chemotherapy, but just so that we put in an understanding that it is not just one person who's doing this. What is happening is there's a multidisciplinary team approach that needs to be taken care of when you're looking at Wilms tumor to decide what is best for this child. With this kind of regimen that we've shown, the overall and event-free survival with bilateral Wilms tumors will still be about 40 to 45% in these patients. I will now hand over to the next speaker who will take you through surgery and the surgical aspects, because that's a very important component of the management of the Wilms tumor. Not just the oncologist, but the surgeon also needs to be very prepared to handle Wilms and know exactly what to be doing when they're opening the abdomen. Thank you so much for your patient hearing.
Thank you, Dr. Ruchira. I'd like to invite Dr. Rasiksha sir now. He's the head of the Department of Surgery and Senior Pediatric Surgeon at SRCC Children's Hospital. He's a pioneer in minimal access pediatric surgery, pediatric oncosurgery, and pediatric urology. He's the first in Bombay University in MCH Pediatric Surgery Examination and awarded the Banu Khambata Memorial Prize for the same. Has had many guest lectures, articles in peer-reviewed journals, presentations, and faculty participation in the conference. Dedicated YouTube channels on pediatric MAS. Past president and honorary secretary of Indian Association of Pediatric Surgeons and Pediatric Endoscopy Society of India. Course director in the Institute of Medical and Minimal Access Surgery Training Center, Mumbai, and has a US patent on a laparoscopic device. Over to you, sir.
Thank you, Ruju. You can see my presentation in here, right?
Yes, sir.
So my presentation will be based on one of these beautiful books, which I think all of us should read if we are interested in surgery or solid tumors, and some other references. So if we see the principles of Wilms tumor, surgery continues to play a critical role in the treatment of Wilms tumor despite advances in chemotherapy. Accurate staging and safe and complete resection of the tumor are key elements in achieving cure. Local control is rarely achieved by chemo or radiation alone. Radiographic imaging is critical prior to resection of renal tumor. It will tell us about presence of two functioning kidneys, whether there is any contralateral tumor, whether there is any intravascular extension. And it is very important that we know if there is any intraoperative identification of intravascular extension, and if it is not detected preoperatively, there are high chances of surgical complications. If we go to the surgical aspects, the incision for nephrectomy. So we take standard is supraumbilical transverse incision. One may take subcostal or thoracoabdominal incision for very large tumor. Struggling through an inadequate incision can lead to rupture, and then the risk, then the stage is increased, and then we end up giving radiation. Flank incision is not recommended in children. So after incision, we will do abdominal inspection to look for the hepatic metastasis, whether there is any spread intraperitoneally. If vena cava can be fed, one should feel it, whether there is any tumor in that, because then the treatment and the approach will be a little different. The contralateral kidney should be palpated for the tumor, although it is not currently recommended that the kidney to be completely exposed and visualized like what we used to do earlier. Exploration of contralateral kidney with opening of the aorta fascia was recommended in earlier NWTS trials based on 5% occurrence of synchronous lesions. In trial 2 and 3, the contralateral involvement was not detected before exploration. By the chances of that was almost 1/3 in with the kids with bilateral tumors. States continuing the review of children with bilateral tumor treated with NWTS in trial 4 identified 9 children out of 122. So the incidence was pretty low, and the tumors were very small, 1 centimeter or 1 to 3 centimeter. And many of them were hypoplastic nephrogenic rash. So steps of surgery, continuing with that, the colon is mobilized of the anterior aspect of the kidney and renal mass. If feasible, the control of hilum is achieved following the ureter superiorly. If tumor is very large, then it is difficult to control the hilum, and then the mobilization of the kidney along with the tumor is performed. Premature attempts to vascular control, particularly without adequate dissection, can lead to ligation of superior mesenteric artery or left renal vein when you are operating on right side, and SMA on the left side. So it is very important that we have all the structure exposed. We know exactly what we are doing before we ligate any structure at the hilum. Biopsy of the renal mass should not be performed unless the decision is not to proceed with complete resection, because it will obstruct the disease. Then it is very important that we do sampling of the lymph nodes. The radical dissection is not indicated, and the sampling should be hilar, suprahilar, infrahilar nodes, aortocaval nodes, para-aortic, and paracaval nodes. At least 5 groups of the lymph nodes should be taken. Important for local staging, because stage 3 needs radiation therapy. Assumption without biopsy has very high false negative and false positive rates of 31% and 18% respectively. An increase in the incidence of local recurrence occurred in children enrolled in the NWTS trial 4, in whom the biopsy of lymph node was not performed, particularly in stage 1 cases, because they will be undertreated and it will relapse locally. As the tumor is mobilized, the ureter is divided close to the bladder, because sometimes there may be VUR which can create diverticulum and infection. Ureteral extension of the tumor may be there, which we may not know. In general, if there is gross hematuria, then there is a possibility of extension in the ureter. Ureteral extension occurs roughly 2% of the patient with the lymph tumor. As for the trial, NWTS trial 345. Gross hematuria, hydronephrosis, or non-functioning kidney. One should suspect possibility of ureteral extension. If we do cystoscopy and retrograde ureterogram, it may aid in the diagnosis of ureteral involvement. If we know it preoperatively, then we can do complete resection of the ureter. If there is any residual disease, then we will end up giving radiation therapy. So if there is upper pole involvement, usually the adrenal gland is removed. Similarly, in lower pole, the adrenal gland can be preserved. The local recurrence can occur, especially when it is stage 3 disease, unfavorable histology, failure to biopsy local lymph nodes and not treated as stage 3 disease, or if there is a tumor rupture during surgery. Most of the tumor ruptures occurs while mobilization of the posterior aspect of the tumor, where it is adherent to the diaphragm. An adequate incision and resection of a segment of adherent diaphragm can prevent the rupture. Resection of the adjacent organs or resection of massive lymph tumor is discouraged because the surgical complication increases significantly. So, as earlier been mentioned by Dr. Preeti, there is we always do pre-operative coagulation in most of our major surgeries, and especially in Wilms tumor, there is a possibility of acquired von Willebrand disease. So one needs to know about that. Now, if it is unilateral tumor, whether one should do partial nephrectomies. So if the indications are tumor of one pole, if it is less than 1/3 of the kidney, and the kidney should be functioning, no involvement of the collecting system or renal vein. Clear margins of between the tumor and surrounding structure should be present. Utilizing these criteria, only 2 out of 43 scans suggested that the partial nephrectomy was feasible. Now, all these references are there in the books. I am not mentioning here. Primary concern regarding preoperative chemotherapy to create resectable small tumor is that these children with small tumor at presentation may be curable by surgical resection alone, as mentioned by earlier speaker. In 40%, in Beckwith reported 40% incidence of nephrogenic rest in unilateral Wilms tumor, where there is increased chances of metachronous tumor if partial nephrectomy is being done. So one has to be careful, of course, if the tumor recurs, then one can go in and take out the rest of the kidney. While role of partial nephrectomy is being suggested in Beckwith, Weidman syndrome, hypertrophy, or WHER syndrome, where one can diagnose the small tumor because the patient are under surveillance. So then word about little discussion about bilateral Wilms tumor. The preservation of renal parenchyma is critical issue for these children. Out of 188 children who were having initial biopsy followed by chemotherapy in the bilateral tumor, 195, or let's just see the majority of them will have complete nephrectomy, some will have partial, and some will have enucleation, depending upon what is possible in such a scenario. Now, in bilateral Wilms tumor, end-stage renal disease occurs in 23 children. of 6-8 bilateral nephrectomy. So obviously they will end up with end-stage renal disease. Bilateral Wilms tumor with favorable histology, event-free survival is almost 74% and overall survival 89%. Unfavorable histology was 40% and 45% respectively. Yeah. So in bilateral disease, again, the chances of end-stage renal disease is about 12% compared to unilateral, which is around 1%. So in bilateral Wilms tumor, upfront intensification of triple agent chemotherapy, then second look surgery at 6 weeks if there is no adequate response, because we don't want to miss on the anaplasia, and definitive surgery at 12 weeks if they respond well. Yeah, then again, bilateral Wilms tumor, many of them on both sides can be discordant pathology, meaning one side favorable, other side unfavorable. So all these are possibilities when we are treating bilateral Wilms tumor. Renal failure we did discuss. So then the intravascular extension, 4 to 6% of the children with Wilms tumor will have intravascular extension. And as discussed earlier, it is very important to diagnose this intravascular extension pre-operatively so that we can avoid intraoperative complication. Ultrasonography can be more sensitive to detect this as compared to CT. The prognosis is not affected as long as we can resect it completely. Traditionally, intravascular extension has been managed with nephrectomy and resection of tumor thrombus. If it is extending into the atrium, then the cardiopulmonary bypass will be required, and then the complication rate is high, but then that is mandatory. So 6%, which we have already discussed, of these patients who had IVC extension and preoperatively while on chemo, 5 patients had complication which included tumor embolism, tumor progression, and 3 had adult respiratory distress syndrome. So not necessarily that because we give chemo there will be no complication. The complication can happen while being on treatment. This is one of the patients where there was intravascular extension, left side Wilms tumor, and this particular patient had tumor progression on chemotherapy. When we started, it was just at the renal vein, and on chemotherapy, it extended into IVC. The chemo was upgraded. Even then, the progression continued and it went into the right atrium. Then patient was operated. This is the patient where you can see the tumor extension. This is the last upper part was in the atrium. This is at the diaphragm. You can see the impression of the right renal vein. And then IVC, this was on the left side. So this is left renal vein. This is intraoperative picture of one of the patients. Yeah. So these are all marking has been done. The word about neonatal Wilms tumor, it's not common, as already I think everybody has emphasized, but it can happen. The differential and other things have been discussed, and the rest of the treatment remains the same. Nephron sparing surgery, that is, in general, a lot of people are discussing today. Absolute indications are when there is solitary kidney due to unilateral renal agenesis, previous contralateral nephrectomy, irreversible impairment of contralateral renal function due to benign disorder, or stage 5 tumor. Incidence of end-stage renal disease is roughly 10%. And today, if we can do it without any problem, then one may consider NSS even in unilateral Wilms tumor, especially if they have associated syndromes. Then one may do it. If there is overgrowth syndromes or hypoplastic nephrogenic rest or any other syndrome, one may consider, because the chances of bilateral disease will be high in them. We will skip this. The technical part we will skip. We have taken care of 3 bilateral tumors. So this is one of them, where it is very important to dissect the renal vein and renal artery and control them. And then you make a scoring like this with monopolar cautery over the tumor. In this particular patient, enucleation had to be done. So it was going into the pelvis. The part of that was extending into the ureter, and from pelvis and ureter, and it was taken out. Luckily for the patient, all this was dead necrotic material, and the child is doing well, I think 2.5 years post-operatively. Same patient at the end, it has been closed. I'll show you a small video of laparoscopic nephrectomy. Yeah. So, two videos playing at the same time. So this was a tumor of the lower. This was actually duplex kidney and tumor arising from the lower part, lower pole, and of course we did not detect it pre-operatively. So it's on the left side. The left colon is being mobilized. These are all vessels which have been dissected. Vessels are being clipped. This is the envelope clip which has been placed. And then the renal artery was very short and there was no space, so we ligated it. And this is the ligation of the renal artery being done. And then with use of harmonic scalpel, all vessels were divided. Then the lateral and posterior dissection was carried out. So that's the lateral and posterior dissection. After it was completely dissected off, it was placed in a bag. And then the lymph node biopsy was done, sampling was done from the 5 groups as discussed earlier. And then it was removed by financial incident. So this is another lymph node. So advantages of MAS in tumor surgery is like same like any other surgery. Additional advantages: chemotherapy can be started early if needed. Long-term survivors in general, they don't like to have unpleasant scars on their body. Scar leads to an emotional distress and negative impact in their quality of life. So when we are discussing about survival, long-term survival and psychological effect, then MS definitely helps. And in addition, there is decrease in adhesive obstruction. I think with that, I will stop my talk and invite Dr. Shweta Bansal to give her talk.
Thank you, sir. Our next topic is post-surgical management with unknown staging. I'd like to invite Dr. Shweta Bansal. Dr. Shweta Bansal is a renowned consultant pediatric hemato-oncologist. She has been nominated as the best hematologist by India Today's Survey 2021 and Outlook Health Survey for top doctors in 2022. She did her specialist training at Rajiv Gandhi Cancer Institute and then at Tata Memorial Hospital in India, followed by bone marrow transplant training at National University Hospital, Singapore. She has also done an IOB fellowship at St. Jude Children's Hospital, USA. Dr. Shweta Bansal worked extensively in the field of pediatric oncology. She received the Best Paper Award at St. Jude Viva Conference, Singapore, 2010 for eliminating cranial radiation from childhood leukemia protocol and showing excellent results for treating with chemotherapy alone. I'd like to invite ma'am.
Thank you, Rajal. Thank you,
ma'am.
Introduction. So I think we've been saturated with all the information we have got about brain tumor so far, but how we do it in practical or in our real case scenarios, it is always better to understand about those aspects also. So my topic of today is the post-surgical management with unknown staging. In the previous talks, we have heard about the staging. So what we meant by unknown staging. Unknown staging is meant when we get the patients in our hospital from different hospitals or from the far-flung areas where the surgery has been done or some treatment has been given and the surgery has been done. And the patient comes with the notes that the surgery of the brain tumor has been done, but no complete surgical notes are there, and even the pathological notes are very sketchy. And then what happened post-surgery on the insistence of the parents or the doctors over there, the tumor of the brain tumor which has been taken out, it gets split into two and sent into two different labs also, in two different pathological labs to confirm the finding that it is brain tumor or not. But as we know now today that we don't need the information whether the patient is having a brain tumor or not, because brain tumor is quite obvious, but we need much more information when we are treating the brain tumor. So my talk is about that. So if you see this, the outcomes of the brain tumor is only based upon the stage. And if we have a complete staging information, we can get the complete, good, excellent outcomes. And depending upon the stage, we can decide the treatment. And the treatment will ultimately not only decide the present outcome, but also decide the main side effects on the patient. As in the first presentation by Dr. Kulkure, you must remember that Madam has said that we are not focusing only about the cure, we are focusing about the total cure and actually the good quality of life post-treatment of these patients, because these patients live normal life and long life. So if you see in this presentation, we have one patient with a stage 1, stage 2 favorable histology. It is having a very good outcome. But if we come down and we see if the patient is having a loss of heterozygosity, which is a molecular marker, then there is an unsatisfactory result. So again, the information has to be complete to adequately treat these patients. So the good outcomes, as I said, it depends upon the correct staging, and correct staging. So it is very, very important to have a proper staging of this patient. And we need to remember when we are treating the brain tumor, only the recognition of the tumor and the operation of the tumor is not enough. We have to give treatment even if it is a stage 1 or stage 2 tumor. So it's a systemic disease in which we need to treat the patient completely, not just by surgery, but by chemotherapy, and if required, radiation also to have a good outcome. So when we are talking about the staging outcome. So stage 1 and stage 2, just to make it very simple, actually stage 1 and stage 2 is the staging where there is a complete resection and the margins are completely negative. And for this, we look at different components, that is pseudocapsule, vessels of the renal sinus, tumor infiltration into the walls of the pelvic system and ureter, renal vessel. In stage 1, these are not involved. In stage 2, even if they are involved, they are completely resected. So this is the difference between stage 1, stage 2 compared to stage 3 and stage 4. And in cases of SIRE protocol, true cut biopsy, if it has been done, it does not upstage the tumor, but any kind of a wedge biopsy, intra-op or during the diagnosis of the tumor, it upstages the tumor to stage 3. While in the NWTS, which is an American approach, any unresected biopsy tumor is treated as stage 3. So these are the few fundamental differences when we are treating with the patients with SIRE protocol or NWTS protocol. So in stage 3, we have incomplete resection. Very important to remember that there is a gross or microscopic tumor is there. Abdominal lymph nodes are involved. Penetration to the peritoneal surface is there. Tumor implants on the peritoneal surface. Tumor rupture is there. Tumor thromboid, which is removed piecemeal. So if any of this surgical finding is there while removal of the tumor, then it is stage 3. While in the stage 4, there is a hematogenous spread to the lung, liver, bone, and brain. So even if the patient is having a hematogenous spread to the lung, liver, bone, and brain, still you have to do a local staging of this tumor. So stage 4 is a systemic staging, but the local stage could be different. It could be stage 1, stage 2, and stage 3. Depending upon that, the local radiation will be given to the patient. So in the treatment of Wilms tumor, every specialty has a major and important role in deciding the outcome of the patient. So radiologist helps us in diagnosing the Wilms tumor. It tells us it is most likely to be Wilms tumor or something else, which Dr. Hirin actually very nicely highlighted in his presentation. And from the radiologist, we need more information. One is that whether it looks like a Wilms tumor or not, or whether there is a mets anywhere in the body, and whether there are any tumor implants in the peritoneal surface, or whether the contralateral kidney looks okay or not, and the lymph nodes are involved or not. So these few information we need from the radiologist. Whenever we are getting the radiological report, we should look into this information. This is followed by a surgeon. Once a surgeon takes over and removes the kidney, we always need to ask the surgeon whether the tumor spillage was there or not, whether the tumor rupture was there or not, whether the lymph node sampling was done or not, or whether the contralateral kidney was looked into it or not. So these few findings again we need to know from the surgeon, and then followed by pathology. And depending upon this, the pediatric oncologist and the radiation oncologist will finally decide the treatment of the patient. So what are the factors actually responsible for the inferior outcomes of the tumor? So they have, many studies have looked into spread of the local disease, tumor size, renal vein thrombus, inferior vena cava, tumor thrombus, lymph node positivity, tumor rupture, and anaplasia, and these all correlate with the overall outcome. However, when the multifactorial analysis has been done, it has been seen that the lymph node positivity and tumor rupture actually are associated with inferior outcomes and increased local recurrences. Similarly, delayed nephrectomy probe actually had fewer complications as compared to the upfront nephrectomy. This has been highlighted by the previous speakers also. So whenever we give chemotherapy followed by nephrectomy, it has been seen the complication rate is less. And the major complication to the upfront nephrectomy was tumor rupture, which was almost seen in 15% of the patients. So the missing components, whenever we look at it, we like to know about the lymph node, whether the lymph node sampling has been done, and if and the biopsy has been done or not. Removal of the tumor, whether it was open surgery, intact removal, whether it was laparoscopic approach was done, whether it was a piecemeal removal of the tumor, or tumor spillage or tumor rupture was there. And the surgical approach, I think, is very important, whether it was transperitoneal or retroperitoneal. And biopsy, it was done, whether So this information is very, very important because this will help us in deciding the stage of the patient. Even if the patient is having the favorable histology or low risk histology, but if these information is not there, we'll miss the bus and the treatment of the patient may get over treatment or under treatment, leading to inferior outcomes. So in the lymph node sampling and biopsy, what we need to see is, so lack of lymph node sampling was the most frequent deviation from the surgical protocol. It has been seen. Absence of lymph node biopsy or sampling actually result in understaging and inadequate treatment. And NWTS, that is American report, showed that those children whose lymph nodes were not sampled, actually they had inferior survival. And the maximum impact of no nodes examined was seen mainly in the early stages, that is stage 1 and stage 2, because they did not have any information of the lymph nodes, they were not upgraded, and they received these aggressive treatment, and they had ultimately high recurrences and inferior survival. So what is adequate number and the site of the lymph node sampling? It has been highlighted by Dr. Rasiksha in this talk. So the number to limit the chance of missing lymph node to less than 10%, approximately 6 to 10 lymph nodes should be sampled. Regarding the site, hilar and para-aortic lymph nodes at the origin of the renal artery, which is a regional node, and the nodes below and above the level, that is extra-regional nodes, should be sampled, even if they are not suspicious. Involved or suspicious lymph nodes must be excised without rupture. So lymph node involvement, how it impacts the outcome. If there is a no lymph node involvement and there is a microscopic residual disease is completely negative, the survival is more than 90%. But if there is a lymph node involvement and the macroscopic residual disease is positive, then the survival is less than 70%. So we have to be very careful about the lymph node involvement and the documentation of the microscopic residual disease in the patients. Now coming to the surgical approach. It's very important to know whether the surgical approach was transperitoneal or retroperitoneal. The gold standard surgical protocol is radical nephrourectomy with lymph node sampling through a generous transabdominal, transperitoneal, and thoraco-abdominal incision. As Dr. Rasiksha has highlighted in his presentation, that minimal access surgery can be done in this patient, but this surgery can be done with very experienced hands and only in few cases where the tumor volume is less than 200 ml and the disease is limited. All other patients should go through a generous abdominal incision to get the tumor completely out without tumor spill and the tumor rupture. In the COG study, almost 50% had at least one surgical protocol violation, and commonest surgical protocol violation was incorrect abdominal incision, and it was almost about more than 5%. What we meant by incorrect incision was considered when the tumor was approached to paramedial or retroperitoneal incision. Retroperitoneal incision leads to inadequate staging and contralateral site visualization. Now coming to the tumor spill. So tumor spill can occur pre-operative also or intraoperative also. I think we saw the images in Dr. Hirin's presentation about the pre-operative tumor spill, which he nicely showed that there was a hemorrhage in the peritoneal surface and the tumor spill happened over there. And intraoperative also can happen. So pre-operative tumor can be spontaneous or traumatic rupture or during the biopsy of the tumor. Intraoperative spill happens because of the rupture of the capsule or during the PCL removal of the bulky tumor or any transaction of involved structures like lymph node, brain or ureter. So it's very, very important when we are removing these involved structures intact so that the spill of the tumor doesn't happen, not from the tumor itself and neither from the other structures like lymph node, brain or the ureter. So tumor spill actually happens, it could be diffuse spillage or it could be local spillage. So diffuse, which is involving the whole abdominal cavity, and those which are involving the local spillage confined to the flank. Again, this information is very important. those patients who were reported to have a diffuse spillage, their treatment was updated and they were given 3 drugs and additional radiotherapy. However, those patients who had local spillage, that information was not given and they were treated with only 2 drugs and no local radiotherapy was given and their survival was inferior. So it's very, very important that the documentation of tumor spill is done properly. And this adaptive treatment can be given, which can include flank radiation. Now, what are the factors which are actually responsible for the tumor spill? In a retrospective study of 41 patients, it was done to understand the innovative risk factors. And the major identifiable risk factor for intraoperative spill was tumor volume more than 1000 cc. And this volume can be told by the radiologist, who can tell you whether the volume is 1000 cc or less than 1000 cc. Similarly, the tumor spill also correlated with the diameter of the tumor, maximum diameter more than 12 centimeters. And the additional factors were renal sinus or IVC thrombectomy. So whenever the patient comes to you with the surgery, post-surgery, with minimal information, try to get the radiology help, try to get the pre-treatment scans, see about the tumor size, tumor volume, lymph node involvement, the tumor implants in the peritoneal surface, any meds like lung, liver, contralateral side involvement is there or not. Followed by surgeon. If you are able to communicate with the surgeon, then it's good. Try to find out about the approach, lymph node spill, sampling, any spill of the tumor, and the extent of the resection. And then coming to the pathologist, it's very important to get the correct staging, which we have already said, microscopic disease and residual there, and which will help us in telling us whether it's a favorable histology or whether it is a risk, whether it's a low risk or high risk histology, depending upon pre or without any chemotherapy. And the final tumor staging work to be done. So this is just to remind you again, once the staging component, these components need to be seen by the pathologist, so that we need to know whether there is a complete resection or not done, or whether these features have been seen or not. And depending upon that, the stage is assigned. So why we are worried about it? Because we need to give appropriate chemotherapy to these patients, and depending upon the stage, we need to decide whether these patients require additional treatment like radiation or anthracyclines. So in the stage 1 tumors, as per the COG and SIO protocol, those patients who are having a high-risk histology, the tumor volume more than 500 ml, or there is a loss of heterozygosity at 1p and 16q, these patients can receive anthracycline. And if the patient is having a focal or diffuse aplasia, then also these patients are eligible for receiving anthracyclines. Then similarly for the stage 2, if it is a high-risk stage or if it is a favorable risk with loss of heterozygosity, then anthracyclines to be added. Or in cases of SIOP, if the patient is having a blastable component, which is a high-risk histology, then anthracyclines need to be added. Similarly, in stage 3, we mostly add anthracyclines, but then we decide whether the patient requires radiation or not. It depends upon the presence of the anaplasia in this patient, or depends upon the high-risk histology and presence of the lymph node involvement. If these features are present, mostly these patients are candidates for receiving the flat radiation also. So management, now we can decide the patients of the unknown staging as small volume tumors or a high volume tumor. So if the patient is having a small volume tumor, which is the volume less than 1000 cc or the diameter less than 12 centimeter, then definitely these patients have less chances of intraoperative spill. So even you don't have information, you can corroborate the information from this radiology report. And then those patients who have low volume tumors with favorable histology or low risk histology, they can be treated with 2 drug therapy without radiation. Anthracyclines in these patients are added if the patient is having a diffuse anaplasia, or whether the patient is having a residual tumor in the resected margins, or necrotic lymph nodes which are positive on histopathological examination. And also, if there is an availability of molecular markers which shows loss of heterozygosity at 1p and 16q, then this can help you in guiding the treatment or the addition of the anthracyclines. Combining these clinical features with histopathological findings can help in prevention of the overtreatment of these patients. Also remember, very importantly, that the patients who do not receive upfront radiotherapy, even if they relapse, they have a better outcomes with established treatment. Hence, the anthracyclines and the radiation should be avoided in low volume tumors until unless it is really necessary. Now, coming to the high volume tumors, how we decide if the tumor volume is more than 1000 cc or the diameter is more than 12 centimeter, they have high chances of intraoperative spill. So, preferably 3-drug treatment should be given to these patients until and unless the high volume tumors with favorable histology or low risk histology are there, which can be treated with 2-drug therapy without radiation. So, addition of anthracycline, we have a low threshold for them. So, focal anaplasia, residual tumor in dissecting margins, or necrotic lymph node positive on histopathology examination, and similarly, if the molecular markers are present. When we add radiation in this group of patients, any patient who is having a tumor rupture, tumor spill, lymph node involvement, or the tumor received piecemeal from any of the involved sites, which includes ureter, renal sinuses, or from any of the vessel where thrombus was present. So in these cases, the radiation needs to be given. So combining these clinical features with histopathological findings can help in prevention of the undertreatment of these patients and prevent the inferior outcomes. Hence, anthracyclines and radiation in this group of patients should be added judiciously in high volume tumors. So this is just a diagrammatic representation, low volume tumors and high volume tumors. Mostly they receive low volume tumors, they mostly receive low 2-drug treatment and no radiation unless sudden risk features are present. And high volume tumors, mostly 3-drug treatment and radiation in case of tumor spill, tumor rupture, piecemeal removal, or wedge biopsy. And most importantly, even if we have a bilateral tumor, we should not do a wedge biopsy in those patients in the contralateral where the small tumor is present. Always do a partial nephrectomy or a wedge resection of that tumor so that the margins are always negative. Because whenever we do wedge biopsy, these patients actually get upstage and there is a high chance of local recurrence in these patients, and hence wedge biopsy should always be avoided in all kinds of circumstances. Thank you. With this, and I would like to end my talk.
Thank you, Dr. Bansal. Our next and last topic for the day is radiation therapy. Dr. Manika Bopai will be talking about it. She is a junior consultant in pediatric general surgery with special interests in the field of pediatric oncosurgery. Dr. Manika?
Yeah, she will upload the presentation and then start. पता है, I don't know about this. Yeah. Yeah.
Thank you, Dr. Raju. I'll cover the radiation therapy in Wilms tumor. I'll try to outline all the methods which are used in radiation therapy. So radiation therapy is indicated mostly to eliminate the risk of local recurrence. The treatment of Wilms tumor is basically multimodality stage and risk adapted approach. But the radiotherapy, whenever it is used, it is the
Yes, everybody to mute.
Dr.
Yeah. So the radiotherapy management varies according to the age of patient, pre-operative extent on imaging, operative stage, and post-operative histology. The indications of radiotherapy. Radiotherapy is indicated in both the favorable histology type and the unfavorable histology. Stage 3 case, tumors, like those with residual tumor, abdominal and pelvic lymph node positives, peritoneal spillage, peritoneal implantation and tumor spillage. In cases of true cut and FNCs, the tumors which are removed in pieces need radiotherapy. Stage 4 Wilms tumors, and the Wilms tumor with unfavorable histologies like anaplasia, clear cell type, and rhabdoid tumor will need radiotherapy. So coming to the dosing, stage 3 favorable histology types need a radiotherapy of total 10.8 gray, that means 180 centigrade per fraction. Stage 1 to 3 focal and diffuse anaplasia will need the same dosing. Stage 3 diffuse anaplasia will need a total of 19.8 gray. Whole abdominal radiotherapy is given in the dosing of 10 gray with a residual boost of 10 gray accordingly. So in cases of metastasis to lung, liver, brain, and bone, the dosing of the radiotherapy is fractionated. In cases of bone metastasis, a margin of 3 centimeter is always included, and brain metastasis need a additional boost with the stereotactic or the intensity modulator radiotherapy. Radiotherapy technique. The timing of radiotherapy should not be later than 9 days after the surgery, because delay has can result significantly to abdominal relapses. Radiotherapy is given in supine position. Immobilization is needed. Sometimes sedation or the anesthesia is also given. The stimulation with X-ray and CT scan has to be given. Shielding of opposite kidney and selected normal structures is needed. Complete vertebra to be included in the radiotherapy field. Flank radiation. Pediatric anesthesia is sometimes necessary. The flank radiation should include the tumor bed and the site of the excised kidney. 2 to 3 centimeter margin should be given circumferentially. The medial border must cross the midline to include the entire width of the vertebra. 4.6 megavolts of beam energy is given in the dose of 10.8 gray. That means 1.8 gray per fraction, and the total of 6 fractions is needed. So this is showing the margins of the radiotherapy. This is the image shows how the contouring and planning is done. IVP is always done prior to this radiotherapy to assess the site of the opposite renal pelvis. Superior border should extend 1 centimeter above the superior pole of the kidney, and the inferior border 1 centimeter below the lowermost extent of the tumor. Whole abdomen radiation, it is indicated in few patients with those having peritoneal implantation, tumor spillage, and tumor rupture. Dose prescribed is 10.8 gray, that means 1.5 gray per fraction. Biweekly hemogram is necessary, and energy of 4 to 6 megavolt photons is given. So whole abdomen radiation, shielding is necessary. you can see with the oblique lines show how the shielding is done. Opposite kidney, acetabulum and femoral heads needs to be shielded. Superior border of this abdomen radiation should be up to the dome of the diaphragm. Inferior border extends up to the inferior border of the obturator foramen. Lateral border include the lateral peritoneal reflections. Lung irradiation or the lung bath. The superior border includes 3 cm above the midline, middle 1/3 of the clavicle. Inferior border, it should it should be extending below the xiphisternum. Lateral border of the areola of the nipple is the lateralmost border. Shielding of humeral head and larynx is necessary. For bilateral Wilms tumor, dose 1/3 of the contact lateral kidney should receive 1/3 of the total dose, and it should not exceed 14.4 gray. In operable bilateral Wilms tumor, the role of cyber-9 tomotherapy, intensity modulated radiotherapy is included. For treatment of relapse, radiotherapy is administered to patients at site of relapse. The dose shouldn't exceed more than 30.6 gray in patients less than 36 months. And total spine dose shouldn't exceed 41.4 gray. Similarly, liver dose shouldn't exceed 30.6 gray. Late effects of radiotherapy, it has effects on, it can affect the fertility of the patients in form of hypogonadism, ovarian failure. Secondary malignancies have also been seen. It can cause other thoracic effects like pneumonia, restrictive lung disease, scoliosis, kyphosis. Secondary tumors in the form of osteosarcoma and breast cancers have also been seen in long term. To conclude, Wilms tumor has a high propensity for distant metastasis. However, the prognosis is excellent with modern day multimodality management. Surgery with chemotherapy is a mainstay of treatment, but radiation therapy given judiciously can reduce recurrences and improve the quality of life. Thank you.
Thank you, Dr. Manika. If we can go to the question answer session and open the chat box, everyone. We have a few questions. Dr. Ashutosh Verma has asked, does USG guided biopsy upstage the disease? Anyone who would like to answer from our speakers?
USG guided biopsy doesn't really upstage the disease, but it has to be done in a retroperitoneal space. It should not be anteriorly, it should be done posteriorly. But we have to remember that this is in context of PSYOP approach, which we talked about, and it has to be followed by, once you prove the diagnosis of Wilms tumor, it is generally within few days it gets, the child is given the adjoint chemotherapy. So in that setting, ultrasound guided biopsy in a retroperitoneal space doesn't upstage the disease, but it has to be followed up by the chemotherapy. Suppose you do the biopsy, prove the Wilms tumor, and then you go for the surgery and your chemotherapy further gets delayed, that is not a good practice. If you do the biopsy, the intention is very clear that you want to start, you prove the diagnosis of Wilms tumor, and you want to take a PSYOP approach and give chemotherapy. So it is within few days. So as I had already mentioned earlier also, that you can't mix up the two approaches. Follow one approach. If it is a upfront surgery, you go for NWTS type of approach and straight surgery. If it is a chemotherapy, then you do the biopsy.
Okay, thank you, ma'am. The next question is by Dr. Patankar. Is pre-op true-cut biopsy mandatory pre-op in Wilms tumors? And if not, what is the percentage of missed diagnosis? Or has anyone in the group encountered missed diagnosis, medical legal implications, and how to counsel the family in such cases?
So the pre-chemotherapy, pre-op is never done, biopsy. If it is operable, you just operate. As I said, if it is a pre-chemotherapy, then SIOP does not advocate that everybody should undergo biopsy. But then there is around 7% chance of over-treating which are not the venous tumor. So this is inherent within the system. So this has to be explained to the parents upfront when you give this approach to the child. That is the no biopsy but straight chemotherapy. But we prefer, because if the neoadjuvant chemotherapy is being given, and we like to do the ultrasound guided biopsy because we may get little surprises, and if it is you can diagnose comfortably the unfavorable histology upfront, then you are not wasting 4 weeks in giving the presumptive chemotherapy with only 2 drugs. So we always prefer, when we are giving neoadjuvant chemotherapy, to do the ultrasound guided biopsy from the retroperitoneum, because it gives you the more confidence to treat the child appropriately.
Thank you, Ma. I think that answers the next question as well. The next question is, I think this is for Sir. How frequently do premier institutions like Tata Hospital or SRCC see Wilms tumors patients referred for post-op management that are operated by non-pediatric surgeons, that is a general surgeon or a urologist? And are these audited separately than the ones operated by pediatric surgeons?
We do see patients who are operated outside by general surgeons. General surgeons not very common. I think mainly it is pediatric surgeons who have operated outside and they are referred for chemotherapy. What was the next part? There were, I think, 2 parts, no?
Yes, sir. And so other part is, are they audited? I mean, do we audit it separately than the ones operated by pediatric surgeon?
Means mainly, I think that Madam will be able to answer more than me. Madam.
See, the technique of nephrectomy remains the same, whether it's a pediatric surgeon or a pediatric surgical oncologist, as we call them. It is the awareness of a pediatric surgeon. That is why Dr. Rasiksha elaborated on the incisions, the way one looks at the nodes, all nodal station, how you should sample the nodes, how you can avoid rupture by looking at a vulnerable spots posteriorly. So all these facts, if known to a pediatric surgeon, the principles of nephrectomy doesn't change. But it is the fact that pediatric surgeon, if not empowered or is not aware of this all nitty-gritty or the finer aspects, then there can be a problem. So that is why you need when it is done by pediatric surgical oncologist or a pediatric surgeon, the difference lies there. We always say that your eyes see what your mind knows. So if a person is not equipped with all this information, he will not look for that. Then it can lead to rupture. It will upstage the disease if you don't do the nodal station picking up centrally. Then again you will not have a correct stage and you can have a local failure. So all these things are very, very important. So ideally it is a pediatric surgical oncologist, but that is a very, very niche area. And pediatric surgeons, I would ask Dr. Rasiksha, how many pediatric surgeons would like to get stamped as a pediatric surgical oncologist, and what is the scope of pediatric surgeons to do this as a niche area?
So when I came back from US, I had option of becoming either pediatric laparoscopic surgeon or pediatric oncosurgeon, and or both, but I selected to be laparoscopic surgeon at that time. Means further interest area. Now being here, I am more interested in onco as well. But a lot of people ask me around 2000 that what subspecialty they should select. And my answer to them was pediatric oncosurgery, one of the area. And I think today there is enough opportunity for pediatric surgeon to focus on pediatric oncosurgery as a subspecialty. In general, we have a lot of centers treating only onco cases, and there is adequate opportunity. I think we have, as of now, 8-10 people from pediatric surgeons who are interested in pediatric oncosurgery, and the number will slowly increase as the institutes also increases. Yes, ma'am. Rujul, you can continue.
Yes, sir. The next question is for Dr. Shweta Bansal, ma'am. Ma'am, Dr. Shalini Mishra wants to know the reference for low volume and high volume tumor classification.
Yeah, so actually, when we are deciding about the low volume and high volume tumors, actually this information we have extrapolated from the COG trials, where they have seen which portion of the tumors or which tumors had a high risk of intraoperative spill. So the COG trials have shown those patients who had a volume of more than 1000 cc, or if their diameter was more than 12 centimeter, these patients had a very high risk of intraoperative spill. So on that basis, we have tried to decide these patients as low volume tumors or high volume tumors for mainly those patients where we don't have a complete pathological staging or a surgical staging, so that we can appropriately decide the further chemotherapy treatment for these patients.
Thank you. Rujul, please.
Okay. Thank you. The last question, see back to it. Is a common pathological staging presentation in India that these tumor patients present with, whether it is 1, 2, 3, or 4? And what is the latent period from the first diagnosis to initiation of definitive therapy? And dropout or mortality rate in chemotherapy, that is neo or post-op related febrile neutropenia mortality? Ma'am?
What is?
Ma'am, I'll start with the first question. What is the commonest clinical pathological staging? What is the commonest clinical pathological staging presentation in India that Wilms tumor patients present with? Like, which is the commonest staging that you've seen maximum patients with Wilms tumor at time of presentation?
It is a wide spectrum, I would say. A pediatric surgeon would see very early stage disease. So if they manage well with their pediatric oncology colleagues, it will be more of a stage 1 and 2. When it goes to the tertiary cancer centers, generally the patients are in an advanced stage or unknown stage, as Dr. Shweta had pointed out earlier, with only one liner saying that left nephrectomy done without a proper histology and so on. So that becomes a patients who are sent with unknown staging or pathological risk stratification. So they carry a higher probability of treatment failure, and they become a risk from that angle. So tertiary centers have a different profile. While I was at Tata, I had seen more of stage 3 and unknowns than was stage 1 and 2. While here we see a lot of stage, quite a early stage. So it depends on the institutional profile.
Yeah, it may be even the socio-economic strata what we are treating. If we are in private corporate hospitals, then maybe we'll stay early stage. If it is government institute where lower socio-economic strata patients are coming more, maybe late disease. I don't think anybody has done any studies, or at least I am not aware, but maybe something like that may be there.
Okay, sir. And ma'am, what is the latent period from the first diagnosis to initiation of definitive therapy? That's the next question.
That latent period is for the diagnosis, basically, as to how patients reach to the oncologist. Because many a times mother's observation of palpating a lump while bathing the child is disregarded. Many a times on the left sided, it is passed on as a splenomegaly. So in this scenario, the renal, like doing a first ultrasound takes few days, and once having done the first ultrasound and knowing that it is probably a renal tumor, then comes that referral to the center. And still there is a lot of hesitancy on the part of parents, the fear that if it is a cancer, what will be the outcome? They are not aware of the outcome. So I would say that a pediatrician awareness is very, very important, that it is such a highly curable disease, and their briefing of or counseling of parents that even if it turns out to be a Wilms tumor, there is nothing lost, and at earlier stage you go, better it is, because you will have a very short treatment and your child will be fine in excess of 90%. So that confidence, if a pediatrician or a pediatric surgeon is able to give it to the parents, it will make a lot of difference. Otherwise, a lot of time is wasted first by the local doctor to order the first ultrasound, generally the few weeks, and then once they say that it can be malignant, there is a hesitancy on the part of parents to go to a cancer center. So this can be filled up, this gap can be filled up by proper positive outlook of primary physicians, primary pediatricians, pediatric surgeon, and counseling the parents in a right way.
Thank you, ma'am. And ma'am, the last question is, what is a dropout or the mortality percentage in chemotherapy? So this is neo or post-op related febrile neutropenia mortality rates.
The drugs, as somebody had pointed out, I think Dr. Chintan, that we have lived with those 5-6 drugs, and they are not very, it's not a very, by all standards of a pediatric oncologist, it's not a very hectic chemotherapy. And probability of losing a child due to the complication, immediate acute toxicity is very low. But at the same time, we have to be very aware of the precautions to be taken for the late effects, because as we all say that it is very highly curable, you are going to live with the child. This child is going to live the whole life ahead and can carry the burden of the late effects. So that is more concerning in Wilms tumor rather than the acute toxicity.
Okay, ma'am. Thank you so much. I don't think there are any more questions. That's the end of the question answer. Yes, sir.
Thank you everybody for attending this session. Rujul, call it a day.
Thank you, everyone. On behalf of all the speakers, we'd like to thank all of you, and thank you, the audience, for this wonderful session. Thank you, everyone. Have a great evening.
Next.